Kính chào quý đại biểu và quý đồng nghiệp. Thay mặt Đại học Y Dược Thành phố Hồ Chí Minh và bộ môn Mô Phôi Giải Phẫu Bệnh, tôi rất là vinh dự được chào đón quý đồng nghiệp đến với hội thảo cập nhật giải phẫu bệnh với Bào Học. Hội thảo này là một cơ hội đặc biệt để cho các chuyên gia, các bác sĩ giải phẫu bệnh sẽ cùng nhau chia sẻ những kiến thức và thảo luận những tiến bộ mới trong lĩnh vực giải phẫu bệnh.
Good morning, distinguished guests, delegates, and colleagues. On behalf of the University of Medicine and Pharmacy at Ho Chi Minh City and the Department of Embryology, Histology, and Pathology, it is my great pleasure to welcome you to the workshop updates in pathology and cytology. This workshop is a unique opportunity for experts and pathologists to come together, share knowledge, and discuss the latest advancements in pathology.
Chúng tôi vinh dự có sự tham dự của Phó Giáo sư Hoàng Anh Vũ, là trưởng bộ môn Mô Phôi Giải Phẫu Bệnh.
We are honored to have Associate Professor Hoàng Anh Vũ, Head of the Department of Embryology, Histology, and Pathology.
Cùng với tiến sĩ Lê Minh Huy là Phó trưởng bộ môn Mô Phôi Giải Phẫu Bệnh.
And Dr. Lê Minh Huy, the Vice Head of the Department of Embryology, Histology, and Pathology.
Cảm ơn hai thầy đã tham dự buổi lễ khai mạc ngày hôm nay. Chúng tôi cũng hân hạnh chào đón các vị khách mời đặc biệt từ các trường đại học của Úc. Xin nhiệt liệt chào đón Phó Giáo sư tiến sĩ Esther Min từ Douglas Hanley Moore Pathology và Đại học Northern.
We are also pleased to welcome our special guest from the University in Australia. Please warming welcome Associate Professor Esther Min from Douglas Hanley Moore Pathology and Notre Dame University.
Professor tiến sĩ Sabanapaki từ Đại học Wollongong.
Associate Professor Sabanapaki from the University of Wollongong.
Bác sĩ Kim Trần từ Bệnh viện St.Geogre.
Dr. Kim Jun from St.Geogre Hospital.
Và bác sĩ Anita Mojuno từ Đại học Notre Dame.
And Dr. Anita Mojuno from Notre Dame University.
Hội thảo sẽ diễn ra trong 2 ngày với các chủ đề quan trọng như là bệnh học melanoma, chẩn đoán các tế bào học tổn thương tăng sinh mô lympho và giải phẫu bệnh đường tiêu hóa, phổi và tuyến vú. Chúng ta sẽ có những cái buổi thảo luận tương tác với các ca thực tế, thảo luận và trao đổi những kinh nghiệm về các phương pháp thực hành hiện nay.
The workshop will take place over 2 days, covering important topics such as melanoma pathology, cytological diagnosis of lymphoproliferative disorders, and pathology of the gastrointestinal tract, lungs, and breast. We will have interactive sessions with real case discussions, providing opportunities for exchange experiences and practical methods. We sincerely thank you for your presence, and we hope that you will have a successful and meaningful workshop.
Ban tổ chức xin cảm ơn sự hiện diện của quý đồng nghiệp và chúng tôi hy vọng quý vị sẽ có một buổi hội thảo thành công và ý nghĩa. Đồng thời chúng tôi xin cảm ơn sự đồng hành và tài trợ cho hội thảo ngày hôm nay. Xin cảm ơn công ty Vạn Hưng, công ty Franklin AI, công ty Quang Minh, công ty Sinh Nam.
We would also like to express our gratitude to the sports for their support today. Special thanks to Van Hưng Company, Franklin AI Company, Quang Minh Company, and Sinh Nam Company.
Sau đây tôi xin trân trọng kính mời thầy Phó Giáo sư Tiến sĩ Hoàng Anh Vũ lên phát biểu khai mạc hội thảo.
Now, I would like to respectfully invite Associate Professor Hoàng Anh Vũ to deliver the opening speech.
Good morning, distinguished professor and guests and participants from the country to our university. Today, University of Medicine and Pharmacy at Ho Chi Minh City very welcome to honor you to participate in the workshop update on cytology and pathology. We all know that this field is very important in modern medicine for diagnosis and also for guiding the treatment for the patient, especially in cancer. So, firstly, I would like to thank you and welcome Professor and expert from Australia. Professor Dr. Esther Min from Douglas Hanley Moore Pathology and Notre Dame University, Sydney. Professor Saban Napaki from University of Wollongong, New South Wales. Professor Kim Chun from Douglas Henry Moy Pathology and St.Geogre Hospital, Australia. Professor Anita Munjulo, also from Douglas Henry Moy Pathology and Notre Dame University, Sydney. So in the workshop, we will receive expert will give a lecture focused mainly on melanoma, lymphoproliferative, and gastrointestinal pathology. I hope that this workshop will actively with discussion from all participants. So I hope the workshop will bring you knowledge and also experience. And we do hope that not only the training and education from this workshop, we look forward for a collaboration also in research, in especially cancer from Vietnam. So thank you very much for coming here, and we wish the workshop will be successful. Thank you very much.
Okay. Sorry, Kim không có hát karaoke cho các bạn. Just translation. So, đây cái mặt vẽ là vợ của mặt vẽ. Mặt vẽ là anh em họ của lúc đó là nhà vua của Anh gọi là Richard. So, Macbeth có một cái người vợ rất là mạnh và bà ấy muốn chồng của bà trở thành vua của England.
Why is King Richard? We didn't talk about King Richard.
Understand. So vua Richard là vua của tất cả England. Ngày xưa thì England là Scotland là hơi khác, mỗi người mỗi cái vùng có một cái vua khác nhau, cho nên nhưng mà vua của England là mạnh hơn, cho nên cái bà vợ này muốn chồng của mình tiến lên trở thành vua của tất cả.
So when Richard visited their home or their manor in Scotland, Macbeth thought, this is our chance. Kill him. Wine and then whiskey and then he got conked, and so Lady Macbeth went into the room with a dagger, with a big knife, trying to stab him in the heart. So sorry, I'm skipping one. She said to her husband, "Yeah, this is the knife. Go and stab your cousin, the king, into the heart, so that when he dies, we can become king and queen." So Macbeth took the knife and then went in. But when he looked at his sleeping cousin, he cannot do it. I can't. So he came out and then he gave the knife to the wife and said, "I can't do it. He's my cousin." And then the wife said, "Oh, you stupid man, you have no courage. I will do it." So she went in and then she stabbed him into the heart. But then also she got scared and she couldn't finish. But then the blood splattered into her face and into her hands. Do we need translation or are you okay?
Need translation? Yes.
No.
So một ngày đó, ngày King Richard đi thăm người anh em Macbeth, and bà vợ của Macbeth nói với chồng là mình phải giết cái nhà vua này thì mình có thể mình sẽ là vua và hoàng hậu, cho nên người vợ lấy một cái con dao rồi đưa ông chồng, nói là vô cái ông vua Richard đang ngủ, mình phải giết ổng mà ổng đang ngủ. Thì lúc mà Macbeth vô thì thấy người anh họ đang ngủ thì ổng trở thành rất là sợ, không muốn giết, cho nên nhưng mà bà vợ nói là phải làm, tại nếu không làm thì sẽ không có được trở thành vua, cho nên bà mới lấy cái con dao từ ông chồng, bà đâm cái ông vua Richard này,
nhưng mà bà yếu, bà không có làm được hết, bà đâm không nổi, cho nên bà biểu ông chồng bà chấm dứt luôn.
Okay.
Nhưng mà khi bà đâm rồi thì máu, bà đâm máu chảy ra rất là nhiều, chảy ra trên mặt bà, trên tay. I say blood splatter.
Okay, blood splatter. That's very important. So the blood was splattered into her face, into her hands. But then the Macbeth went and killed. But for Lady Macbeth, so because the blood was everywhere, she went and washed herself. She couldn't get rid of a spot of blood on her hands. There was a spot that is there. And every night when she sleeps, she remembers this pigmented spot. And that spot, she was trying to wash it out, and she couldn't. And this is when she said, damn spot, ouch, I want this out. But then she couldn't. So she went crazy because of a pigmented lesion on the hand. So pigmented lesions could be small, but they are dangerous. So I'm going to go from Lady Macbeth's spot to the spot on every New Zealand, and it's here too in Asia, but then we miss a lot.
So sau khi mà cái ông Macbeth này giết cái người anh vua thì họ là thiên với lại hoàng hậu, nhưng mà trong cái trong đầu của cái bà vợ này thì bà lúc nào cũng nhớ về cái máu mà đã phun ra từ cái ông King Richard, mà cái máu này có một cái spot, một cái phần cái máu nó dính cái vai của bà, cho nên trong cái trí của bà lúc nào cũng nhớ về cái vụ này, cho nên từ từ bà trở thành điên. Cho nên nhưng mà Esther nói là giống như cái một melanoma ở trong cái người mình, nhất là người Úc với lại người Tân Tây, người New Zealand thì nhiều khi có cái mụn thật là nhỏ nhưng mà có thể làm bự và có thể hại cái sức khỏe của mình, cho nên Bảo muốn dùng cái chuyện này để nói về một cái spot. Tại nhiều khi mà máu nó nằm trước đó là đỏ, sau khi mà nó cũ nó sẽ thành đen, phải không? Nó giống như là melanoma vậy đó. Is it good? My translation?
Well, I don't know. Is it good translated? Yes, okay. So I'm an eternal teacher. An eternal teacher is I will always, from the moment I open my eyes in the morning until I sleep, I think of teaching and then being a teacher. So your homework is, if I come back next year and if I ask Macbeth, and if you cannot answer, you will be in trouble. Okay? Promise? You promise from the back? Will you read Macbeth? Yes? No? Yes. Will you read Macbeth? Yes. Over there, will you read Macbeth? Yes. Okay. Everybody promise. So I have a lot of witnesses. Yes, director? Yes. Oh, you will read too. So I'm going to start my lecture on melanoma. And I did this especially because of Ty. So Ty was with me on February of this year. And then I brought him into my office, and my desk, and I was reporting dozens of melanoma. And he looked at it, and there were other two Vietnamese pathologists. And we may be missing this. I said, melanoma is not very common in Vietnam, but then please teach us. And he inspired me to bring this. So thank you, Ty, and you should thank him. This is one of the reasons I'm here too. He said I have to come. So let's go to the very, very basic of skin and how melanoma happens. So this is the skin where you have the epidermis. It's not an arrow. Is it still okay? It's a hand rather than an arrow. Okay. Yeah, okay. So the epidermis, you have the 5 layers of the epidermis from the. This is too difficult. I'm no technology, so this is the basal layer. Okay, we call it the stratum basalis, and then you have the spinous layer, and then you got the corneal layer that is always renewing. And then you have the papillary dermis, where the collagen is loose and nice and soft. And there is no native thick collagen. It's just a homogeneous thin layer. And when you look at the beauty pages and you see this contains collagen and you rub on your face and you will become beautiful, they lie. Okay, so we can't have any collagen in the papillary dermis. And then in the deep reticular dermis, you have the thick bundles of collagen. Collagen has to be made by the body. Okay? You cannot inject collagen into the skin as well. Then, under the reticular dermis, you get into the subcutis, the fat cells there, and where you have at the papillary reticular dermis subcutaneous junction, you have the hair follicles, you have the sebaceous glands, and even in the reticular dermis, you start to see blood vessels and nerves. So this is the structure of the skin is very important in when you are staging or when you are doing the Clark levels or bracelet thickness of the skin of the epidermis. If you think of the melanoma just here, which we call it melanoma in situ, the chances of this metastasizing to any other place is minimum. If you go down, if the bracelet thickness becomes thicker, and then if it encroaches the blood vessels and nerves, the chances that it's going to metastasize become greater as it becomes deeper. So this is very important to know that has melanoma invaded? Where did it invade? Into the papillary or to the reticular dermis? Do you need a translation for this or not? Very good. I know so. Oh, yes, as long as you get what we are giving, no matter if you talk or to sing to each other, we are fine. Yes, you can do everything. I want you to get what we have. And we have flown 8 hours with Anita bringing all the class slides like this so that you guys get it. I don't want you guys to just sit and listen and get sleepy and then go home. Okay, so I'm going to check on you by asking questions. I know who you are training, which year you are. So you cannot sleep. You have to open your eyes and listen. So, so melanoma incidence is increasing in the white population, but in Australia and New Zealand has the highest in the world. So we became experts in this. But then, you see, I was trained, my first pathology training was in my home country, Myanmar. It was called Burma before, but it's called Myanmar now. And I'm responsible to teach medical students and trainees specimens of the body. And we have metastatic melanoma of every organ, even in my country, in 40 years ago. So I think we share the same environment, the same temperature, the same exposure to sun. So you will have the same problem as well. So you may miss melanoma. So I don't want you to miss melanoma, which if we can catch it in the early times or when it's a beginning, then we can cure it. So the major environmental risk is UV light. And then like the director sitting over there, it's genetic susceptibility. If you have genes to have melanoma, you will have, and then immunosuppression. When you are exposed to ultraviolet light, you have intermittent exposure or chronic exposure, and both of them are dangerous. If you think that, oh, I don't go out into the sun too much, it's not, and I will be safe. No, it's not that. Even if you have intermittent, you go in and out, or you have chronic, you stay in the sun all the time, you have the same risk factors. So the critical time, the important time is when you start to have exposure to sun when you are a child. When you let your children play in the sun too long and if the child has sunburns. So, but then in Vietnam and in like Burma, we're not very worried about that because we don't have the ozone hole, etc. But we don't know about the genes that we have. So make sure that even if your family, friends, if they have cumulative sun exposure, make sure that they must be aware of the damage that can cause. So head and neck melanoma is due to chronic exposure. The trunk is due to if you have multiple nevus. The acral or the fingertips, if you have drivers, you have high exposure. Ocular, like if you have to look up to the sun, and especially the farmers. So we know what causes melanoma, what are the risk factors, just not the sun, the genes, but then what are the types of melanoma. So we have nodular melanoma, superficial spreading, lentigo melanoma, acral melanoma, and desmoplastic melanoma. So this is what a nodular melanoma looks like. So to diagnose a nodular melanoma, the melanoma will occur in like a nodule. So it's like a solid lesion, quite well circumscribed, and then growing vertically down rather than horizontally. And you have almost no junctional component. So it goes straight in, and this is one of the very dangerous subtypes of melanoma. So lower power, you can see that the melanoma starts from the top, but then it does not have the junctional component, and then it grows in. So melanoma can look like anything. It looks like you have round cells. It doesn't have square cells, but then it could be like spindle. It could be polygonal. It could be stretched, slender, thin cells, epithelioid, just looking like squamous cells, or it could look like liver cells. But the only thing that melanoma does not look like is they don't look like glands. If you are seeing glandular structures, the chances of being a melanoma become less. Spindle, very common. Epithelioid, very common. Round cells, very common. Polygonal, very common. So if you are very lucky, you will have intracellular or extracellular melanin pigment. which is brown pigment within the cytoplasm, or this could be in the surrounding stroma. The superficial spreading melanoma is, if you look into the junctional component, and I went to the Gucci tunnels, and I saw there's a shooting range. So have you ever seen a shotgun, a double barrel gun? Do you understand double barrel? Yes, everybody. I'm sorry for thinking that you don't. So when a double barrel gun shoots, bullets go spread like a buckshot. So you get these melanoma cells, single or little clusters everywhere on the full thickness of the epidermis. They are in nests. They are large, big nests, or small clusters, or 2 cells, 3 cells, but they spread like they shot from a double-barrel gun. And then it invades into the dermis. And then, see, I was taught by the melanoma expert of the world, my mentor. It's called Professor Stan McCarthy. So he said, Esther, because in Australia, if you have melanoma and the pathologist miss the melanoma, you are going to be sued. The lawyers come and say, why did you miss melanoma? So my professor taught me that, Esther, there are 2 things that will never miss melanoma. The pathologist will miss melanoma, but the lawyers and the lymphocytes will never miss melanoma. So if you think there is melanoma, look for lymphocytes. So the lymphocytes are trying to find and attack the atypical melanocytes, because the body does not like. So they respond by trying to attack using the T cell pathway of immunity. So lentigo maligna melanoma is usually, it happens in cumulative chronic sun damaged skin, and then it grows along the epidermis without going high up, without having any pegydoid spread or buckshot spread. They grow along horizontally, and then they go into the hair follicle and the annexal structures. So they are also, but because it's not superficial spreading, this is still a dangerous melanoma. But the important thing is, if you catch early, it can be cured. I'm going to repeat again. If you can catch it early, it can be cured. So acral lentiginous melanoma is when you have it in the acral part of the body. Then you can have it under the nails. And see, I got only the pictures so that it looks dangerous and looks nice too. So then you have different types of cells, like I told you, very common spindle cells, polygonal cells, small cells, round cells. And then you have the subungual under the nails. And then, but then whenever you see a line in the nail, it's not always melanoma. So don't really, whenever you see it, don't start to get frightened. There are other things, other features that I will talk about. So when you see, I want you to learn this. When I go, take this out, cut it, and then put it near your work table, so that whenever you have, your clinician asks, there are colored lesions where in the part of the body where it is not skin colored. So you don't have a little bump, which is black bump. You have to worry. Or a brown bump, which is different from the skin color. And it's an uncertain diagnosis. I don't have a pinprick. It's not bleeding. I don't have any trauma. I didn't have this 5 years ago or a month ago, and it just popped out. Any lesion that does not have a definite diagnosis, please worry. Okay? If there is bleeding of those lesions underfoot or under the nail, whether it's direct bleeding when it's dripped off or it's oozing of fluid, and if it looks like granulation tissue, you have to worry. And then when there is a lesion or ulcer that starts to, no matter what the treatment is, it's not getting better. And when it is not healing, when you try to heal, but it's still ulcerate and bleeds in 2 months' time, this is not a good lesion. So we have to, whenever you think of melanoma, age is important. Usually melanoma is the disease of old people. So if you have young person, think of more benign rather than malignant. As usual, for men are more susceptible. Women, we're okay. So we are less susceptible. The site, if it's on the face, the arms, the back, bad. The flank, and when you are covered, when you wear clothes on, it's better. The tumor is thick, it's bad. If plaque level is higher level, from 1 to 5, the higher the plaque level, the worse. Brace low thickness you measure from the granular layer of the epidermis. If it is mitotically very active, when it is growing down deep, very bad. Ulceration, very bad. When you have lymphocytes, it's bad. And then when you have the features of regression, where you have fibrosis or vascular proliferation, it's bad. And when you have satellites or little new melanoma spots away from the major lesion. So I want to talk about the brace load thickness and Clark level and the 10-year survival rate. If it is Clark level 1, 10-year survival rate, Clark level 1 is you measure from the granular layer of the epidermis to where the melanoma is. If the melanoma is in Clark level 1, it's still not within the epidermis. The chances are 1, 2, and the papillary dermis is 93%. 10 years, you will live. When it comes down to the papillary dermis and reticular dermis junction, where you have the blood vessels there, then the chances drop down to 71%. If it goes into the reticular dermis, then it drops 59%, it's become worse. But if it's going into the subcutaneous, the patient will live 14 months. So you have to know how dangerous the Clark levels are and the brace load thickness is. Brace load thickness is you measure from the granular layer of the epidermis. And then if it is less than 1 millimeter, it's good. Or we call it the thin melanoma. And the thicker the brace load thickness, the worse the prognosis. Okay, after I have scared you to death with melanoma that in Clark level, you are going to live only 14 months. There are pigmented lesions in the differential diagnosis that are not melanomas, but you have to know them. So you have pigmentation of the basal keratinocytes. It will be dark, it will be brown, but they are not melanomas. Increase in melanocytes in hyperpigmentation. They are benign nevi, they are dermal melanocytic lesion. And my favorite topic is the final one, or the dysplastic nevi. So what is basal hyperpigmentation? So basal hyperpigmentation is, you see it's under the influence of hormones, and you can see it in young girls or women who are going through menopause when the face starts to have black or brown spots. Every woman hates it, and they go to the laser clinics and this and that because it's part of the aging process where the keratinocytes are not of good quality anymore, and the melanocytes the pigment starts to leak out, and it's called freckles as well. And then it will be not on the melanocytes, but the keratinocytes of the skin. So it's flat and then very common in the shoulders or have sun exposure, racial pigmentation in pregnancy and in other, if you take other medications containing heavy metals and drugs. So if we always think that, well, I come from Asia where homemade medicine and homeopathic or traditional medicine is very important. Every household, my grandmother, my mother, we have to have this little powder from a bottle somewhere and then eat it, take it. This is good for digestion. This is good for lung. You won't cough. But if they have arsenic or antimony, which we don't know, because arsenic is usually used in traditional medicine so that it is a preservative to stay for the medication not to get bad. And this can also cause problems. Increase in basal melanocytes, you are born with that. And then you can have, it's not melanoma, when you take a biopsy, it's just pigmentation and then not in the melanocytic area. So these are the other increase in basal melanocytes. And you can see the different pigmentations. So you can see this, where the clear cells are the melanocytes, and usually the melanocyte stays every 10 keratinocytes. This is solar lentigo, where you have little foots of the epidermis coming in. You can see pigmentation of the mucosa. This is on the mouth, where you start to chew. So, and then we call nevi. So I think everybody is trying to sleep now, so I'm going to wake you up. So we'll start from the back. Okay, so what is a nevus? Do you know what a nevus is? Okay, no, I'm not going to take one person. It's too scary. So you can have that group over there, starting from the 4 girls to the back where 2 is. What is a nevus? Come on, you have to give me an answer. What is a nevus? Well, you are all included in that group. The man who is with the handsome man at the back, who is trying not to look at me, is also included. Okay. Okay, what is a nevus? Come on. See, they are not going to get any points. Okay, this side, the young ones. So what is a nevus? Come on, young ones, you're going to beat Professor Tu and all. Okay. But come on is thank you, but I'm trying to say it in English. Come on, what is a nevus? John, can you help them? You are part of the group. Yes, please.
Okay, so a nevus, when it's called in Vietnamese, it's called a nốt. In Vietnamese, we usually call it a nốt ruồi. Yeah, it's a terminal in Vietnam. And in English, a nevus is the proliferative of melanocyte neoplasm. So usually it's a benign lesion.
It's a benign lesion, yes, but I'm not sure we call it a neoplasm. It is when you have two or when you have 3 to 4 melanocytes in a group, it is called a nevus. So how does nevus happen? So I'm an eternal teacher, so you have to know the history of how nevi happen. Come on, Thai, and I taught you that. Okay, and so no, you are not included, but you know that. See, from the back. So how does nevi happen? I have an idea of what a nevus, how they become nevus, how they become 3 or 4 on the epidermis. It's like Lady Macbeth. It's a story. You want another story of a nevi? Yes? Oh yeah, you like stories. So during when the embryo starts to see, how does the embryo form? How many layers are there? 3 layers. Very good. What are the 3 layers? The ectoderm, the mesoderm, and the endoderm. So the melanocytes are when the body is still not formed yet, when it's not a fetus yet, the melanocytes are in the ectoderm. Okay, but then they have to cross all the tubes to the top layer of the skin. So when they are crossing through all the layers, they come to the epidermis. And then when they come to epidermis, they meet friends. Usually they are saying, okay, you are made so that you are going to protect the skin from the sun. For every 10 keratinocytes, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, we have 1, 2, 3, 4. So this is how the body designed this. You will have every 10 keratinocytes looked after by 1 melanocyte. But the melanocytes, they want friends. They don't want to stay alone. So they say, okay, you don't go, stay with me. And then this anomaly starts to happen. So instead of staying 1, it becomes 3 or 4. And this is called a nevus. But the body does not like anything extra. So you are forming a group. If you form a group, you can become a rebel. So no, we don't want that. You have to. So what happens is when these groups are formed, it's called junctional nevus, because they say in the junction of between the epidermis and the dermis. And they can stay there. And by the age of from 10 to 20, they have to drop down. So from the junctional nevi, they drop into the dermis to form. They're still junctional, and then they have the dermal component as well. So they become compound nevus. So by the age of 20 to 30, if you have a compound nevus, it's very benign. It's following a normal pathway. So when it comes to the dermis, they start to mature. Mature means they have to shrivel up and die because they are too much in the body. Come down. And then by the age of 40 to 45, you shouldn't have the junctional component left. It has to be the dermal component only. So by 40, 50 years old, you should have only the intradermal nevi. If you have junctional nevus only after the age of 60, is it normal? What do you think? Okay, the front row. Junctional nevus should be in the young age, and then they drop to form compound, and then they drop more to form intradermal nevus, and they mature and they disappear. But if you still have junctional by the age of 60, it's abnormal. So if you have a 60-year-old man in the back of the body with junctional component only, more melanocytes than keratinocytes, It's no longer benign. So nevi are very important because they could be precursors of abnormal melanocytic lesion. So compound is after junctional, they drop into the dermis. So you have the junctional component and the dermal component. And then afterwards, there is no more junctional component and only the dermal component. So benign nevi, I've just told you that. And then most nevi have stopped growing by the age of 20. And then the maturation when they drop into the body, but then the maturation are slower in the palms, the soles, and the genital region. Some nevi are present from birth, but usually after a Spitz nevus is, it looks horrible, but then they are benign. A halo nevus is the nevus with a little halo around, or it is regressing. Congenital nevus is when it involves the adnexal structures. You have the different types depending on how much cytoplasm it has. Myasthenic nevus when it is associated with eczema. Deep penetrating nevus is when it is not maturing when it goes down. So these are the other nevus which are rare and wonderful, but not very common. So I've just talked to you about Spitz nevus, the halo nevus. That's a halo nevus where you have the depigmentation surrounding it. So this is the halo nevus is due to the regression by lymphocytes eating away. Congenital when it involves the adnexal structures. Dermal, so when the melanocytes travel up, so they can be arrested during the when they are going from the neural crest during embryogenesis. So every child of Tibeto-Mongolian descent will have the Mongolian spot, which we all have this when we are born, but it's very uncommon in the other Western countries. And this is how it looks like under the microscope. It's in the spindles, dermal pigmented lesions. So it's on the face, it's on the hands. Blue nevus is when it is very dark, but then it's deep down. They are all benign. Looks horrible, but it's benign. Okay, this is my part that you have to learn. What is a dysplastic nevus? Dysplastic nevi, they don't follow. They don't fit in with melanomas yet, but they don't follow the benign nevi as well. So a nevus with cytologic and architectural atypia of the junctional component, it is between a common nevus and melanoma. What is the time now? Am I 9:40? Oh, yeah, we have time. Thank you. Is it better from the back? Good, yeah. You have to tell me. I won't know. See, I'm in the lecture. Okay, I'm an eternal teacher. So if the group, and remember, you have the benign nevus. Benign nevus will always be well circumscribed. And it could be macule, but then they are round, well circumscribed nodules. But this is not. The size is very important. If the size of the lesion is small and less than 5 millimeters with no color variation, then it's usually benign. If it is more than 5 with color variation, it's not good. It has, and the periphery is uneven, and it has to have erythema or redness around. So what do you mean by architecture? Yeah. There will be nests of varying sizes. It could be in the basal layer of the epidermis, and at the tips, there will be single cells. There will be lateral extension. So usually when we call, there is symmetry, where you start with a nest and then you end with a nest. But if you have a out, then it's not. When nests are bridging, and then there is suprabasilar scatter, but not reaching the granular layer. You will have lamellar fibroplasia and patchy lymphocytic infiltrate. If you have that 8 features, it's very worrying, but it's still not melanoma. For melanoma, you have to have lentiginous or continuous growth of the melanocytes. Then we have to think of not architecture only, cytologically. Yeah. So the nucleus would be enlarged, like any malignant cells. It should be neighboring adenocytes. The chromatin will be clumping, and it will be darker. There will be nucleoli, and there will be lots of mitosis. These are here. Mitosis is very, very, if you see mitotic figures, the chances of being benign. Oh. So what can we do to help us? We can do S100 special stain, but S100 stain is not trustworthy. You can be friends with anyone. So you can have nerves, it will fat cells, it will stain soft tissue, it will stain cartilage, it will stain brains, it myoepithelial cells. It's specific, but not sensitive. If you think it's a melanoma, it has to have S100 positive. If you think it is, if you see S100, it may not be melanoma. But if you think that it is melanoma, it must be S100 positive. Am I making it clear or not very clear? Clear. Okay, good. And then Soxten. Soxten, I love Soxten. I use Soxten a lot. And then Soxten is a transcription factor. Then Soxten is, you can see out in melanocyte. Myoepithelial cells, you can see that is around ducts and glands. So when you are seeing around ducts, then you know that it's not melanoma. But then if it is staining in somewhere where some structures that are not these, then it's important. You can use HMB45, melan A, and then these are, I use Soxten more than any other stains. Brain is the the new emerging actor now. It's very popular, like the Korean movie stars. He looks very handsome and good. But then now, later, after a little while, they have so many competitors now. So brain is 10%. You can have 10% of melanomas not staining and 10% of benign things staining. So how do you use brain? So if you think that there is melanoma, and if you see, and then under the H&E, if you see a benign nevus, benign melanocyte staining with brain, you use that as your control. So you can use brain, but you use your own cells for internal control. So I was taught by Thomas Brent, who positive and negative control that we supply, it has to be the internal control of the. So H&E is still the gold standard. So summary, so if you think this is melanoma, you have to think of the width is 4 centimeters, more than 4 centimeters. If you have architectural problems of irregularity, bridge, and then you have increased density of non-nested junctional melanocytes, then keratinocytes, you have to worry. And the presence of cytologic atypia is. So I'm back to the dysplastic dysplasia. So previously there are the low-grade dysplasia is when the melanocytes, the histology, the nuclear size is 1 to 1.5. The variation is small and random atypia. And the architecture is also lentiginous spread. You can measure not more than 0.5 millimeters. But high grade, the nuclear site has to be big. It must be hyperchromatic, larger cells, and then there is more nuclear variation with architectural atypia. So prognosis and predictive factors. So why do we have to diagnose nevi? Why is it very important? So there are so many schools of thoughts that you don't want to diagnose a dysplastic nevi. So there are now 2 different schools in the world, especially in Australia, whether there is one side, say no dysplasia, it's melanoma or nevus. But the other side is there is nevus, there is dysplastic nevus, melanoma. But do we really diagnose dysplastic nevi? Yes, we have to, because the genes for dysplastic nevi is different from common nevi and melanoma. There is genetic evidence that is. But then, why do we have to also? It looks melanoma, but you don't need to overtreat because it's a dysplastic nevus, but you have to be aware because it can be a potential precursor of melanoma, and then it has the risk of becoming melanoma. It could be a precursor, it could be a risk, and it could be not melanoma. So when you look at this slide, it's not very clear. It's all muddled up. So a dysplastic nevus can simulate, it looks like melanoma. %3 group. When you report dysplastic nevus, that 3%, 33.3% will not become melanoma. Your family member with a dysplastic nevus on the nose here, what will you do? It's a dysplastic nevus. It will 33.3% then can, but 33.3% will stay as it is. What will you do? Your family member on this, will you nose? Want to cut the nose? Leave it? Or what will you do? Come on. You are pathologist. You are responsible for your patient. Okay. Okay. What will you do? Come on, Ty. What will you do? It's your what will you do? Will you cut the nose? Or will you leave it? No, the biopsy is that it's a dysplastic nevus. You have to treat now. What will you do? 33.3, it becomes melanoma. 33.3 will not become melanoma. 33.3 is going to be like this. What will you do? He doesn't have a girlfriend, so he can't think. You have a girlfriend? Yes. Oh, no, not yet too. Okay. Okay, who has a girlfriend? Young, you have a wife, so you are more important now. Yeah. Oh, you're certain now. Okay, so sorry. Okay, you have to think. What will you do? So it's if it's on my face and it's become a dysplastic nevus, I'm going to chop it out. I don't want to. I like my nose. I want to keep it. But what will I do? But it has 33.3% chance of becoming melanoma. So I'm not going to cut it. I'm going to make sure that the dermatologist is my best friend. I'll go and see him every month, every 3 months. Look at it, look at it. Is it getting big? So you can wait and watch. But if it starts to grow, if it starts to become bigger, if it starts to change color, it does not heal, then cut. But if the same thing is on the back, I will go quickly and say, cut now, cut it. And then I'll forget about the melanoma. So your responsibility of a pathologist when you are helping your clinician is very important. They rely on you. So you have to make sure that is the patient, it becomes your patient. Is that you have to be very close with your clinical dermatologist or with the surgeons. They must know you and you to trust them. Are you sure that they will come back to you? If they come back to you, make sure that you follow up every 3 to 6 months. So this is where I work. And I work, this is my room here. Okay. Okay, so the practical points here. The age of the patient, the gender, and the anatomic position is very important. So if Trong have a pigmented lesion, if Young has a pigmented lesion here, and if I have a pigmented lesion, I would worry more. You can wait because nothing can happen. But I'm a woman. I have to worry. Sabah have the same problem. He has to worry more than me. And then it's the anatomic side. If it's on the shoulders, the chance is great. The lesion, you worry more. Clinical description, like it's not healing, it's getting big, it's colored. and then you know your patient, you know your clinician. If your clinician said it's never happened and I'm worried, if he is worried, you worry too. You can overcall because you trust your clinician. You have to form a group. You must know the dermatoscopic and always ask for a photograph to see whether it's an uneven picture. So how do you biopsy? Because you may not biopsy, but you have to teach your clinician what to do if there's a pigmented lesion. Your preferred technique is not biopsy. Okay? If it's a punch, you want you want the entire breath in the. If the lesion is not transected, if you can't get the lesion elliptical shave biopsy or a big partial sampling is in the fingers, but you want the whole lesion. If the biopsy is not good, you have to ask for a good biopsy. So you will be asked for surgical margins. Please recommend how big I have to cut. So it is the treatment of choice for cutaneous melanoma. Have to have histologic negative margin. Histologic, under the microscope, the lesion must be clear. So what do you need? So melanoma should be at more than 2 centimeters, clinically measured around the primary tumor. And for melanoma in situ, after your diagnosis, they have to go to 1 centimeters is recommended. But if it is a lentigo maligna, you may need more than 0.5. So melanoma in situ, 0.5 to 1. Superficial spreading, yes, but if it is lentigo maligna, maybe more, depending on where it is. So I think if you report pigmented lesion, this is your Bible, and you have to have this on your desk under somewhere so that you can just look at it. Non-surgical treatment, which it is for where the clinical excision is not, you can't do it. There is radiation therapy, cryotherapy, and but none of the non-surgical is not properly studied yet. So when do we do sentinel node biopsy? So sentinel node biopsy should be considered when the melanoma is 1 millimeter or more thicker. So it's the sentinel lymph node biopsy is the important prognostic factor of the survival rates. If the bracelet thickness is less than 1, it is not recommended. It should be 0.75, then you should discuss. And then if it is more than 1.5, you have to suggest. So we go back to dysplastic nevus. Do you observe or do you cut? It depends if you have a family history, if you have a past history, and if it's in the age and site, and it is very dysplastic, if it's an old man on the neck, shoulders, arm, treat like melanoma in situ. Although they don't have enough features to call it melanoma in situ. If you have family history, if you have a past history of melanoma, dysplastic nevus should be treated as melanoma in situ. So I'm going to give you the practical tips of what I do. So If there is a atypical lesion, which is if the size is big, it's an old man on the back, and the quality of skin is very sun damaged, cut. If it is, pretty ridges are not formed, flattened, then the junctional component oozing, cut. If you just look at the cytology, if there is, it is more than the adjacent keratinocyte, very little cytoplasm, nucleoli, mitosis, cut. If there are nests, if the lentiginous proliferation is more than 0.5, if there is pegytoid spread, if it's coming along hair follicles, cut. If there's asymmetry, cut. Call it melanoma in situ or dysplastic nevi suggests formal excision. What is a lentiginous junctional nevus? Which this is a term that I don't like, but then a lot of people are using, but you have to have your own understanding. If there is one small net and 3 to 5 and only few scattered melanocytes, just one nest. So if you have a nest, you have to call it a nevus. But then if there are a few nests, a few single cells around it, and all of them, you have to call it a nevus, but some people add lentiginous because there's only one nest. But I just call it a junctional nevus so that it will not confuse the clinicians. So I'm going back again for this because it's very important of the 33.3% rule of this is your responsibility. So this is what is atypia again, what is moderate atypia, what is severe atypia. So in children, you want to downgrade because in children, it becomes very alarming. It looks very bad. If pegytoid apert emigrate at the periphery, you see some cells going up, even if it is halfway, if it is at the mitotic finish at the base of the dermal component, but no matter how bland it looks, upgrade to. So melanoma in situ is if the size of the lesion is big, if the lentiginous spread is this much, there is upward, or if the junctional nests are irregular, call it upgraded into. It's you guys' turn now. So this is a 66-year-old. So when is a 66-year-old man, if there is only junctional, is that, or is it benign or malignant? 66. So, malignant, very good. You don't have to look down first, okay? It's a pigmented lesion, 66, I'm thinking malignant first. And then you look at it. You see there are nests there. We're not very, I want to see whether it's going up. So you put this chain in red. Look at how much melanocytes are, and we don't see rotation. So what will we call this? This is lentiginous, superficial, spreading pattern of melanoma. Is it invasive or not? Oh, yes, very good. It's melanoma in situ. You can work for me now. Okay. So it's at the scapula. It's really, you know this is a wrong site for a lesion. It's a 51-year-old female. 51 is difficult. Whether it's, you can still have a little bit, but if you have no dermal component, are you going to worry? Yes, you're going to worry now. It's only junction. What is a 51-year-old woman trying to behave like an 18-year-old woman? Right? She's not 18. Should be no junctional component. And you can look, is there any keratinocytes in? Almost, it is lentiginous proliferation with petit widespread. This is also melanoma in situ. Superficial spreading. So this is also the same thing. So this woman have two sides. Look at that. Okay, this is from the woman right ear. Very sensitive now. You want to chop the ear or not? It's a problem. So under the H&E, you see the component. Component. Up here, I can't see much. If you look at these cells, this is a lot bigger than these. When you have, are you going to worry or not worry? On a 51-year-old man having this, there is a junctional, there is a dermal component and a functional component. This is what we need in the histochemistry statement. Of course, it's here as well. This bit looks not bad. So when you do the SOX test, you don't see. So how far will you go with this? Yeah, next you have the keratinocyte, you have the component, you have this. The ethnic cell structures are not involved. That will be good. It's in the ear. You want to pull back? Or you want to go ahead and call something? Although it's not very, it's almost contiguous, but then it's not very wide. So, and we have pictures of irritation here. So this is too much. We call this melanoma in situ. Actually, yeah. So I'm going through this again. We have done this. We have the. I'm stressing this because I need to guys to get the dysplastic nevus component very well. What is margins? When will you say this is clear margin? Where will you measure margins? Since we have this. I thought the pictures are not, it's not showing the entire lesion. So, but you can see that there are really typical cells along the epidermal junction. We've got lymphocytes, we don't know what's hiding underneath. So this is where we need a SOX test. So if you want to call it melanoma in situ, it is curable, highly curable, very little risk for recurrence. And the 5-year survival rate is 8% from 2020. So if you call it melanoma in situ, you are giving the patient, yes, you're going to have a normal life. So you have to make sure that the margins are clear so that the patient can have a good, clear result, report. So melanoma in situ, no chance of metastasis, malignant system, which you need to excise it well. The mean exit the marks was 1.9 compared to the average of 3.8. That is not in the study. So this is a study that we did. And in institution of wide local margins, histologic margin of at least more than 3 millimeters is required to achieve low recurrence. The rate of recurrence decreased with increasing histology. So the wider the margins, the better of you stopping a recurrence. How do I report? So this is Esther's way of reporting. I will never say that the margin is clear because we are not seeing the entire specimen. We see 70 to 80% of the lesion, but that's it. So I will always say that the margins appear clear. I don't say the margin is clear. I say it appears clear. So I'm trying to step between the boundaries for legal reason. I measure how far the melanoma in situ is from the peripheral or lateral margin, and the clinicians can assess how far they have to cut. So I measure with a rod sextant and frame, but then if I have frame, I can still do it with a red sextant. So because I need to know that it is not the bad keratinocytes that I'm staining or the post-inflammatory pigments of the melanin that I am measuring. So if you have this, where would you measure from? From here. Where would you measure from? From here. So this side is measuring from here. Side, are you going to measure from here to here or from here to here? Where would you measure from? Kim, where would you measure from? Because if you have to measure from the class, okay. So when you have, you'll have a not single cells. You can take it as still benign. Measure from the nearest, the furthest cluster. So where would you measure from? From here? Well, this is the good picture to measure. Okay. I measure where there's definite vertical line from the top to bottom. So if you measure, see, I don't measure from here. Okay, I would measure, if this is a cluster, I would measure from here. This is, because it is a slanted excision. If the atypical melanocyte taper off are less than this, if they are tapering off and the intervening keratinocyte are less than 10, you take it as it's from the same region. So where would you measure from? From here, from here, from here, and there. Because if you measure from here, because it's so nothing, then it's okay. If you measure from here, that you're going to cut a huge lesion. And if it's on the neck, then you have a like twinkle star with. So when you report on certain areas, it's very important that everybody is relying on you. So make sure that you know what you have to have your limits and you know what you are doing. So where would you measure from? Sabah, where would you measure from? This is significant. So we're going to measure. If there is one side of the hair follicle is involved, so where would you measure from? So this is all part melanoma, and you have to measure from, not from this side, from whole entire hair follicle has to be measured. If there's a star plus melanocyte or a ring nuclei, even if it is beyond 10 keratinocytes, you have to I can't read it, so okay, so but you can read it. So and it's just around 10 keratinocytes. I want to know about the sites and 10 keratinocytes and melanocyte ratio view. Right? If there's a wandering nest, you measure to put this in whether it's 10 keratinocytes or not. So like this is a wandering nest. From here. The 30 cells group. So this is only in 2 papers, but it is really important. If they are scattered melanocyte, it is not fit with any of the above. It's not a group of cells, it is not lentiginous, then you do it with a high power and count. If there are at least 30 melanocytes, then the margin is positive. So like this is a 30% group. So you can see that is 0.2 clearance. You count this, and I think this is 31 cells. So you have to say that this is positive. And if the 30 epidermis is cut out, the 30% rule still works. If you only have this bit, you have to sit on under high power and count for 30 cells. So these are the references for that. So this is my first lecture. I'm going to have more time.
Thank you, Professor Esther, for your wonderful presentation. And before we move into another part of our lecture for today, I would like to give a summary for your presentation in Vietnamese.
Okay.
Xin phép được tóm tắt cái bài báo cáo của Phó Giáo sư Esther bằng tiếng Việt ra. Thì tóm tắt một số kiến thức căn bản quan trọng trong bài ngày hôm nay cũng có là đối với UH tố ác tính melanom là một loại ung thư ác tính có tỷ lệ mắc bệnh cao ở các quần thể da trắng, đặc biệt là những người ở khu vực gần xích đảo như là Úc và New Zealand, nơi mà có mức độ bức xạ tia cực tím ở mức độ mạnh, và đây cũng là một trong những yếu tố nguy cơ môi trường chính. Ngoài ra thì có các cái hình thức phơi nhiễm liên quan tới các trường hợp tiếp xúc với tia xạ UV, gồm có tiếp xúc ngắt quãng hoặc là liên tục, các trường hợp mà phơi nhiễm ở tuổi ấu thơ hoặc là tích lũy qua nhiều thời gian dài, gây nên tình trạng làm cháy nắng có thể tăng nguy cơ đáng kể của melanom. Bên cạnh đó thì các yếu tố di truyền cũng như là tình trạng suy giảm miễn dịch cũng đóng vai trò trong sự phát triển của melanom. Trong bài báo cáo thì có nói nhiều loại u hắc tố khác nhau, và trong đó có thể kể đến như là loại nodular melanoma, thì đây là loại phát triển nhanh chóng và có xu hướng xâm nhập sâu vào da ngay từ giai đoạn đầu và thường không có giai đoạn phát triển theo chiều ngang trước khi xâm lấn. Đối với nhóm thứ hai là nhóm superficial spreading melanoma, là loại u hắc tố lan rộng theo bề mặt, thì đây là loại phổ biến nhất và có xu hướng phát triển theo chiều ngang trước khi xâm nhập vào da. Đối với loại thứ ba là loại u là melanoma loại lentigo mariner, là thường xuất hiện ở các vị trí da tổn thương do ánh nắng kéo dài, phổ biến ở người lớn tuổi và đặc biệt ở các vị trí ở trên mặt. Đối với các u hắc tố ác tính ở chi là nhóm acrolentiginous melanoma. Đây là nhóm hiếm gặp và thường xuất hiện ở lòng bàn tay, lòng bàn chân, ở dưới móng tay, phổ biến ở những người có làn da sậm màu. Các trường hợp hiếm gặp hơn có thể kể đến như là nhóm melanoma hình thoi hoặc là nhóm dưới móng. Đây là các trường hợp khó chẩn đoán và có tiên lượng rất là kém. Có thể kể đến các yếu tố tiên lượng mô học quan trọng đối với melanoma được kể đến như là tuổi, giới tính và vị trí. Các yếu tố này có thể ảnh hưởng tới tiên lượng và vị trí chống sót, chẳng hạn như các khối u ở đầu cổ và thân thì thường sẽ có tiên lượng xấu hơn so với các trường hợp khác. Đối với độ dày của khối u, đó là breast flow thickness là một trong những chỉ số quan trọng nhất. Khối u càng dày thì tiên lượng càng xấu. Các trường hợp khối u dày hơn 4 mm thường có tiên lượng kém. Đối với chỉ số phân bào thì tốc độ phân chia của tế bào cũng có tiên lượng tới khả năng xâm lấn. Các trường hợp có phân bào cao thường gắn liền với các nguy cơ xâm lấn cao hơn. Sự loét của bề mặt là một tiên lượng xấu cho thấy khả năng xâm lấn và di căn cao hơn. Tỷ lệ lympho bào thâm nhiễm khối u cũng là một trong những yếu tố quan trọng chỉ ra đáp ứng miễn dịch của cơ thể, và các trường hợp này sẽ có tiên lượng tốt hơn. Đối với việc chẩn đoán u hắc tố ác tính phụ thuộc vào đánh giá lâm sàng và kết quả sinh thiết. Trong đó phương pháp sinh thiết ưu tiên đó là cắt bỏ hẹp toàn bộ tổn thương, đảm bảo rìa âm tính và đủ độ sâu để đánh giá toàn bộ khối u. Các trường hợp sinh thiết hạch lính gác được khuyến nghị cho các trường hợp khối u có độ dày lớn hơn 1 mm để đảm bảo phát hiện di căn vi mô ở các hạch lympho. Tuy nhiên thì cái việc đánh giá sinh thiết hạch lính gác này vẫn còn gây tranh cãi vì tác động của nó đối với cái tỷ lệ sống sót chung. Khuyến nghị đối với việc có rìa phẫu thuật tương ứng, trong đó có thể kể đến là các cái tổn thương melanoma tại chỗ thì cần rìa phẫu thuật từ 0,5 tới 1 cm. Tuy nhiên các trường hợp lentigo và mariner thì rìa phẫu thuật có thể phải lớn hơn. Đối với các trường hợp của u hắc tố xâm lấn, rìa phẫu thuật phụ thuộc vào độ dày của khối u. Trong đó, các trường hợp khối u có độ dày dưới 1 mm, tức là chỉ số Breslow, thì rìa phẫu thuật trong trường hợp này là 1 cm. Các khối u dày từ 1,01 cho tới 2 mm thì rìa phẫu thuật từ 1 cho tới 2 cm. Và các trường hợp khối u dày trên 2 mm thì rìa phẫu thuật là 2 cm. Cho thấy việc đánh giá độ dày Breslow là một trong những yếu tố cực kỳ quan trọng vì nó có liên quan tới phương thức điều trị. Các trường hợp không cần phẫu thuật có thể kể đến mà liên quan tới điều trị thuốc. Tuy nhiên thì các trường hợp này người ta vẫn khuyến cáo là vẫn còn nhiều gây tranh cãi. Trong bài thì có đề cập tới các trường hợp của nevus nghịch sản là nhóm dysplastic nevus, là một trong những cái tổn thương mà có thay đổi cả về mặt lâm sàng và mô học. Tuy nhiên thì nó nằm ở trung gian giữa tổn thương lành tính và ác tính. Các trường hợp này đòi hỏi cần phải quản lý phụ thuộc vào các yếu tố như tiền sử gia đình, vị trí, tuổi và mức độ không điển hình. Trong đó mức độ không điển hình của nevus nghịch sản được chia thành hai loại và là độ thấp và độ cao. Sự khác biệt lớn giữa hai trường hợp là liên quan tới nhân tế bào cũng như là các cấu trúc. Ngoài ra thì các trường hợp liên quan tới tiến lượng và các yếu tố dự báo có thể kể đến như là việc sử dụng dấu ấn Brem là một trong những trường hợp là các trường hợp mà liên quan tới dấu ấn Brem này có thể có nguy cơ tăng cao về mặt xâm lấn và tái phát. Trong đó thì giáo sư cũng có nhấn mạnh thì tiêu chuẩn vàng trong việc đánh giá của melanoma vẫn phải là ở trên mô bệnh học, tức là trên HE. Xin cảm ơn ạ. So, Professor Esther, we would like to give you two questions about from the audience. Before we moving to the next part, the first question is, what is the role of breast flow thickness and clot level in evaluating the melanoma prognosis, and how do they affect the terminal treatment, the treatment conditions?
Okay. Breast low thickness is you measure from, when we first started the skin anatomy picture. The breast low thickness is you start from the granular layer of the epidermis, almost the top part, and then you measure it from the granular layer to the deepest cell of the invasive melanoma. So if the treatment and the prognosis depend entirely on the thickness, like I elucidated, like I told you before, in the reticular dermis, you have the blood vessels, you have the lymphatics, you have the nerves. The deeper the melanoma get into, the more chance of them destroyed and get metastasized and carried away by blood, by lymph, by the nerves. So the thicker the breast low thickness, the worse the melanoma is. The treatment has to be, if this is more than, the thicker the breast low thickness, the wider the excision, and then the more the neoadjuvant that you have to add. If the breast low thickness is less than 1, less than 0.75, it's called a thin melanoma. You cut 0.5 to 1, and you are cured. You say, oh, I don't have melanoma in situ. Bye-bye. But then it becomes 1. Okay. The chances of you living is the patient living is 59% compared to 92.3%. And even if you cut more, you don't know whether it has gone into the lymphatics or not. So you have to have a wider excision, and then you may need radiotherapy, or you may need adjuvant chemotherapy or immunotherapy, like in the new days. Now we have BRAF inhibitors can be used. So breast low thickness is number 1. Breast low thickness is number 2. Breast low thickness is number 3. Breast low thickness is number 4. Breast low thickness is number 5 in the prognosis and treatment of melanoma. If you know how to measure, and if you don't put it in your report, you are practicing criminal medicine. Can you explain that?
Giáo sư có nói là việc đánh giá cái độ sâu của breast flow thì chúng ta sẽ tính từ lớp hạt của trên biểu mô da, lớp hạt của biểu mô da bình thường ở vị trí giữa của tổn thương tới cái vị trí sâu nhất của tổn thương. Thì cái tiêu chuẩn của thang điểm breast flow là một trong những yếu tố cực kỳ liên quan tới việc điều trị cũng như là tiên lượng. Trong đó thì các trường hợp là breast flow mà dưới 1 mm thì việc điều trị là chỉ đơn thuần là cắt bỏ tổn thương độ với cái rìa âm tính là từ 0,5 cho tới 1 cm là đủ. Tuy nhiên đối với các trường hợp mà xâm lấn lớn hơn 1 mm thì nó cũng có liên quan tới các vấn đề về việc xâm lấn vào các cái trường hợp mà xâm lấn vô cái hạch lympho, và đó là lý do vì sao và việc đánh giá sentinel lymph node trong trường hợp này nó có ý nghĩa quan trọng. Và các trường hợp mà càng xâm lấn lâu hơn nữa ở breast flow từ độ 4, độ 5 thì chúng ta không thể đảm bảo hoàn toàn cái việc mà lấy toàn bộ tổn thương ra khỏi. Thì đó là lý do vì sao mà tiên lượng của bệnh nhân sẽ drop, tức là sẽ rớt từ 95% cho xuống tới còn 50%. Do đó thì việc chúng ta ứng dụng cái đánh giá cái breast flow ở trong thực hành lâm sàng là một điều vô cùng quan trọng, và đó là một trong những yếu tố mà chúng ta nên ghi vô trong report để đảm bảo và việc điều trị là tốt nhất cho bệnh nhân. So thank you. So I would like to give you a second question for today. Under difficult entities, just like you can differentiate between melanoma and other entities. So what is the immunohistochemistry do you usually use in your practical day? And there are some entities that with lot of treatment. So how do you do in that circumstances?
See, whatever it is, H&E is the main gold standard. You cannot report without an H&E. Okay. In my practice, I use SOX10 more than anything else. SOX10, why do I use SOX10? Because SOX10 is a nuclear stain. It is not like S100 is a cytoplasmic and membrane stain, so it's very messy. And it's also stain other things as well. So you have to, if you don't know what you are looking at, then you will miss it. But then instead of using a brown stain, because melanoma, the melanin pigment is brown. It's like hemosiderin, it's like melanin, so whether it's the hemosiderin from the bleeding, or is it the melanoma, the melanocyte, the melanin from the melanocytes, or is the melanophage trying to get rid of the melanin pigment and it clutters, and is it a macrophage or is it a the melanocytes? Who knows, right? Under the H&E, this has become really difficult. But you have to know, okay, this is what I want to look at with an immuno. This cell, I don't like it. This area, I don't like. This is either, is it melanophage or is it a melanocyte? Is it lentiginous or is it somewhere else? Is it lymphocytes? Is it melanocyte? I use SOX10, but I use red SOX10. Red SOX10. Use a different chromogen. Don't use brown. With brown, it will be the same. You will still be very lost. So, and when do I use it? Whether if there is, I know that with H&E, it's melanoma in situ or invasive melanoma. I know it with H&E, but I still use it on 3 occasions. One is it's unequivocal. You know that this is it, but you still use it on 3 occasions. One, if you are dealing with young children, you cannot afford a mistake. Think of it as your child or grandchild. And then because the treatment is surgical, you have to cut. If you cut, what part of the body, you don't want a big scar. The smaller scar is very important. So in children, even if you know whether there's this and that, you do an immunostain so that you are very sure and you can breathe and sleep at night. Okay, number 1. Number 2, you trust your clinician. Your clinician is very worried. And he said, is it melanoma Esther? I've looked at this lesion for 2-3 weeks, and this is getting I'm not happy. And I look at it, and it's benign. It's nothing there. But I cut more levels because you have to have a rapport or trust with your clinician when you report. It's not just that I just do it. No, you have to have a rapport. If your clinician is worried, then you do it. See, for young children, for your clinician, when you worry it's in the wrong side, wrong place, always do it. And then when you are not sure, like the margins, okay, because you have to cut. And it's your responsibility to tell you how much to cut. Do a SOX10. And you won't be sued too. If the lawyer wants to come, no, I have a SOX10. Okay.
So what we do in the past, when I was trained, I also trained at Royal Prince Alfred Hospital under Stan McCarthy and like Esther. And what we do there is we use potassium permanganate, and we bleach the pigment. So when the pigment is bleached, there's no more pigment, then you can use your the usual brown stain. But it's a very messy procedure. Not many people do that anymore. So the problems with melanoma is mucosal melanoma, like the eye melanoma, because our eyes are pigmented, and our normal mucosa is pigmented. And when you have a melanocytic lesion, it's very difficult. So I think if for expense reason, if there's one red chromogen you get, it should be SOX10. I think it's really worth it if you do a lot.
Dạ, thì giáo sư có nói là trên HO vẫn là một trong những tiêu chuẩn cực kỳ quan trọng để mình đánh giá melanom. Ngoài ra thì việc sử dụng SOX10 với lại là S100 cũng là một trong những hai cái dấu ấn mà giáo sư hay sử dụng. Tuy nhiên thì khuyến khích sử dụng SOX người nhiều hơn, tại vì đây là một dấu ấn ở trên nhân tế bào, còn S100 thì là một dấu ấn ở trên bào tương. thì nó sẽ biểu hiện với lại rất nhiều và gây nhiễu trong các trường hợp chẳng hạn như là đại thực bào hoặc là các trường hợp xuất huyết. Thì đây là các trường hợp mà có sắc tố ở trên đại thể, tức là trên vi thể, mình thấy rất là nhiều. Do đó việc sử dụng dấu ấn sóc 10, cụ thể là dấu ấn sóc 10 phải là sử dụng cái loại mà bắt màu đỏ thì mới có thể giúp ích và đánh giá tốt trong việc đánh giá melanôm. Và các trường hợp mà khuyến khích nên sử dụng, thật ra thì sẽ có 3 trường hợp mà khuyến khích nên sử dụng hóa mô miễn dịch, bất kể việc mà mình có nghĩ rằng đây là tổn thương ác tính hay là lành tính hay không. Thứ nhất là giáo sư có nói đây là các trường hợp ở trên trẻ em, trên con nít, tại vì đây là các trường hợp mà mình cần phải cân nhắc việc phẫu thuật, nó cực kỳ quan trọng. Do đó là nên áp dụng hóa mô miễn dịch vào trong các trường hợp này luôn, mà không nên chủ yếu dựa đơn thuần vào HE. Và thứ hai là khi mà lâm sàng gợi ý là các trường hợp này là ác tính thì chúng ta cũng nên thực hiện hóa mô miễn dịch mà không nên chỉ dựa đơn thuần vào việc đánh giá trên HE. Can you repeat the third options that you would like to do a ear stent without any prostate? Yeah, before it's for children. Clinical suspicion and the third one is yeah. Trường hợp thứ ba là khi mà mình không chắc chắn thì mình thực hiện hóa mô miễn dịch. Đó là 3 trường hợp mà mình nên là áp dụng hóa mô miễn dịch, và mà bất kể khi mà mình không còn khi mà mình cần sử dụng hóa mô miễn dịch, đó là cái trường hợp đó. Thank you for the share. So before we move into our next part, I would like to you guys to come outside and have a break, and also have a tea break for us that we prepare today. Thì chương trình xin phép là được dừng lại một khoảng thời gian để cho mọi người dùng tea break cũng như nghỉ ngơi, và mọi người có muốn trao đổi gì đó trực tiếp với các giáo sư thì mình cứ tự nhiên tới hỏi thăm mình. Cảm ơn tất cả mọi người.
Okay, this time, you are going to talk, and I'm not going to talk at all. Okay? So whoever Nhi is going to be marking down who got it right for tomorrow, you get your prizes. So, but if you don't answer, you won't get prizes. Yes. But you're not going to cheat. I know that you have a QR code. Do not cheat, okay? Oh, no, you can't because you don't have the answers. Yes, yeah, no, that's the QR code. You can look at the slides. Okay, to question 1, please. Question 1 is, have you all looked at the slides that I've sent you before? Did they look at it? Okay, see, I've got, I know that you have looked at it. So you cannot say that you haven't, okay? But if you haven't, then you can have a look here. Look at it now. Okay, it's easy. So case 1 is a 30-year-old female with ultrasound-guided FNA of the right breast lump. It's a 15 millimeters lump of the right breast. Okay, next slide, please. So this is what we see. Okay, Nhi, what do you see? Okay, come on, tell me what you see. Do you see slides, or do you see cells or no cells? Is it a cellular smear or not cellular smear? It is a cellular smear. Okay, so if you look at the cells, are they cohesive or are they spread out? Are they clumped together? Okay. There are a lot of single cells in the background. Okay, you've got these big clumps and you've got single cells. If you look at the clumps, what do you see? Cytology is also, it's art. I love drawing, so I love art. When you look at cytology, you have to imagine things happening. You need to I think they all get this. Do you need translation, or you are happy with this? You happy with what I'm talking? Yes. At the back? Yes. Not. Yeah. So if you look at the cells, the cells appear to be full, right? They have to be full. It's not just like one cell, full. And the background cells. So can you have the next slide, please, too? So if you look at this, you can see that the cells are pulled. I think I can show it from here. Yes. Yes. So if you look here, see, these are pulled. This is pulled, and then this is a huge chunk. But the single cells at the back, what shape are those? Are they round? Are they spindle? Are they oval? You have to go back to your slide. Okay. Oval, very good. You get 1 mark. Yeah. Oval cells and, okay, next slide, please. Oh, look at that. So it looked like a teddy bear to me. Okay, it's like a koala bear. You have the face here. And then you've got the ears, and then your little hat, and then pull back. And then what is this here? You think mucin? Okay, what do you think this is? It's not mucin because you have some cells inside or strings of things inside. It is stroma cell. He gets 1 point, one point. Yeah. See, these guys are getting prizes. You have to work a little bit harder, okay, from the back. So, and then this is another section of stroma. This is stroma there. This is stroma there. And this lesion is from a 34-year-old girl from the breast. Okay. 1 more slide, please. This is the PAPS tape. You can see that so in a breast, if you want to think that this is benign or malignant, in the ductal epithelial cells, what is the most important thing? You can have mitosis because with hormonal influence. So it's not mitosis. What is very important? No, cytologic feature. So because breast ductal epithelial cells are always, if it's benign, they have the myoepithelial cells stuck to it. And you see what you call that? It's a bimodal pattern. You see the epithelial cells and the myoepithelial cells. So if you look within that, you see these really small dark cells stuck to it. So it's all cohesive. You've got the myoepithelial cells in the background. If you look at this tissue fragment, it looks like to me like a reindeer going away, running reindeer. You can see the big horns. You can see the head. You can see the body. You have to imagine, this is cytology. See, you can see that reindeer? Yes, they are seeing reindeers. Good, what's their name? Yeah, they see reindeers, they get a prize. Okay. And what is the back? What is this there? Okay, not you guys, the guys in the back. What are those cells? What is that back? The above fragment. It's fibromyxoid stroma. Very good. Yeah. Okay, another slide. So this is a close-up of the cells. Do you worry these cells or worry? Not worried. Why don't you worry? Yeah. See, because all these cells are very predictable. They look exactly like each other with stromal fragments. And you can see the myoepithelial cell in close proximity. Okay, next slide. What's your diagnosis? Wow, who said that? Yeah, you're going to get it. Huh? Okay, what's your diagnosis? Fibroadenoma. Let's see whether it's fibroadenoma or not. So, see, when you report cytology, you report this way. I have to tell you about this presentation. This is the presentation that happens every year in Yardsticks course in Sydney. And this is presented by Dr. Irene Wu. She is a cytopathologist, and I'm presenting for her. These are her cases. This is her work. The slides are from her, and she wants me to show it to you guys. So you know Dr. Irene Wu ahead of seeing her. She may come here in the next years. She wants to come too. So now I've stolen her cases. So it's not non-diagnostic? It's benign, or is it atypical? Is it suspicious, or it's malignant? So next slide, please. So the expected answer is a benign pattern, and it's fibroadenoma. If you say fibroadenoma like you want a present. And then if you just say it's benign, you have, it's a borderline answer or a borderline diagnosis. One more slide. So this is how you write cytology report. They are highly cellular. They are branching sheets of ductal epithelial cells. You see myoepithelial cells. You see a bimodal pattern. There are numerous single bipolar nuclei in the background. There is fibromyxoid stroma, no malignant cells. So you have to explain what you see, and then there is no chance that this is malignant. You have to put this: no atypical cells and no malignant cells are seen. So the diagnosis is fibroadenoma. Good. Next slide. The second line, there is a bimodal pattern. The picture. Yeah, so you can see that they are really dark cells. Like this is a very good one just here. See where you see a really dark cell, but you see the pale clear cells? Dark cells. So it's called bi because it's two. One clear, one dark, bimodal, two types of cells, see? And they are in close association. Bimodal, close association, branching pattern with adenoid. They're bipolar nuclei. So this is not difficult. Guys know your cytology. So this is the type of slides that you get in the final exams for the Royal College exam in Sydney. This is all the same type that you get it in the international exams in the UK. So if you know this, you are halfway to become a fellow pathologist. Okay, go on. No need to worry. So what can you help to do this? Ancillary testing. You have a cell block. I think I'm too old to be turning backwards. I'm going to sit here. Okay. When you do a cell block, what else? So if you do have a cell block, a cell block will give you like H&E section where you have, with H&E stain, you will see the features of fibroepithelial lesion. So we have just explained that. Can we move on? Okay. So next case. As a 22-year-old female, a young girl, In the parotid, it's a fine needle aspiration biopsy. Next slide. See, okay, let's start with Thai from the back. Thai, what is this? Is it cellular, not cellular, quasi-cellular, or acellular lesion? It's cellular. Very good. Thai gets a present. And then, next slide. See, you can see fibrovascular cores. And then you see this clusters of cells. They look predictable. In low power, they look cohesive. There are a few cells that are out, but then you can see the proper fibrovascular cores. Next slide. Same thing, but you can see single cells. Some of them are slightly larger, and then with some cytoplasm. Some of them, if you look down here, you have the clear cells there, clear cells there, clear cells around. So this look like the primary salivary gland tissue. Next slide. So you see the same thing. Primary salivary gland cells, like acinic cells over there. Most of them here, and then they are stripped nuclei, but then you can see like a little ring or a glandular pattern. You think can you imagine what this is by now? Yes, no? Is it salivary gland tumor? Is it primary or metastatic? Or benign or malignant? Can anyone say from now, yet or no? Benign. Answers already. Something is benign, it's just but then if in a young person, if you needle and if you have a cellular smear, it's not. It could be benign, but it is already a neoplasm. It's a lesion. Okay? It's not just a normal tissue. Something is happening. It's a cellular smear. Go on. You see this? So there are acinic structures. They are round. The nuclei are very round. And then it's predictable. Some of them has a little small nucleoli. Okay, more. Go on. So similar cells in Diffquick. Go on. Okay, in PAP, you're seeing more. You see acinic structures. You see a lot of cytoplasm. They are in cords and strands and acinic structures. More. So what do you think now? It's a cellular structure with just acinic structures. The cells have a lot of cytoplasm. So is it an oncocytoma or is it acinic cell tumor? Okay, go on. So we have to think of, is it acinic? Is it just a lesion or is it just benign tissue? So for me, this is too cellular just to leave it as it is a neoplasm. So whether it's a benign or malignant, we have to look more. So your diagnosis now, what do you think? It's a tricky question now. What do you think? You think pleomorphic adenoma. Do you see fibronuclear stroma? Magenta color stroma? Yeah, maybe you have to think, okay, it's still in the good differential diagnosis. The next slide. What else? The one have said pleomorphic adenoma, which is a really good answer. What else? Carcinoma. Okay. So it's pleomorphic adenoma, acinic cell carcinoma. So let's go. It's a diagnostic material. We're not sure that so it is suspicious for malignancy, or it's, let's say, malignant. And let's look at the next slide. It's highly cellular, poorly formed acidic groups, blood vessels, pleomorphic punctate chromatin. The background is clean, no dirty background, no adipose tissue or salivary duct epithelial cells are seen. So next slide. It is the diagnosis, the best diagnosis is a primary salivary gland neoplasm. And then the differential diagnosis for that is it an acidic cell carcinoma, oncocytic neoplasm, or a secretory carcinoma? I'm not sure I like secretory carcinoma, but I'm okay. I take the first two. So I like neoplasm. But then for me, I will put in like the differentials. The primary neoplasm, but then I think between these two, or others, and you can just put in others, and then further investigations are necessary. Next slide. So you can do a cell block, and from the cell block, you can do immunohistochemistry. So for acidic cell carcinoma, we can do DOG1 and SOX10. Secretory carcinoma is hemoglobin. Oh, the molecular guy is no longer here. So we can ask him about the secretory carcinoma, and then ETV6, NTRK3 translocation, or NR4A3 translocation. And we have immunos now. Okay. So further investigations were done, and then this was the histopathology of the same lesion. So what is this? So it is a malignant neoplasm with the granular, you can see the granules of the zymogen granules of the acidic cells. So this is the next slide. So, the next slide, please. So it is acidic cell carcinoma. So that's a normal perfect then, and then you can have the variation of that. Okay, next slide. Top one, staining. So it's Milan category 6. Next slide. So what is cell carcinoma? It's a low-grade malignant salivary neoplasm. It's uncommon. Only 3% mainly occurs in the parotid gland. It is in a younger age. It's a slow-growing mass, but it's always need to include the differential diagnosis when you have acidic cells in that. So in general, surgical excision is curative, but there are a subset that can metastasize. So if you have acidic cell carcinoma, long-term follow-up is essential. You have to tell that it has to be, you have to take it longer. Okay, next slide. Next. So the common causes is like even here with very experienced cytopathologists, it's false negative because it's not very common. And then sometimes you don't see the necrosis pleomorphism, and it looks like a normal salivary gland tissue. So that's why we had a problem there. It can be mistaken for hyperplastic salivary gland. But for me, it is too cellular to call it just a. Okay, next case. Oh, so it's a highly cellular. It's a clean background. You have glandular cells. The nuclei are uniform. There's abundant foamy cytoplasm, large number of naked tumor cells, not mixed with fat or normal ductal cells. Oncocytic, there is an oncocytic variant as well, but then you have dense granular cytoplasm. So acidic cell carcinomas are quite rare. So when you have a chance again, look at this slide carefully, because this is the typical classic picture of cytology in an acidic cell tumor that you have to think of. So, tissue. Yeah, I get it. Anything. Low grade is a problem. So the important features for the young ones, if you have a single population, think it's going to be bad. You need some friends there. If you have no friends, no ductal epithelial cell, just a monomorphic population, worry. Okay, good. So I'm giving you the Milan classification. You have to know the Milan classification if you are doing exams, because you may not need to put it out in the report, but for exams, you need to know it. So non-diagnostic, non-neoplastic, atypia of undetermined significance. Then neoplasm is 4A and 4B. And then benign is 4A. Uncertain is 4B. Then suspicious and malignant. So we need to know the Milan system for the management and the risk of malignancy. So atypia is you can repeat FNA. And then if it is neoplasm, you have to have surgery. And then if you are suspicious, whether you need en bloc, you need neck dissection for lymph nodes, the surgeons and the oncologists have to decide. Case 3. So this case is not difficult. So you will know this. 62-year-old female smoker. So it's a smoker, it's an old woman. Left upper lobe, it's a mass lesion. There's a big tumor there already. And then PEP is evident. Okay, slides. Wow, look at that. I think it's very beautiful. It's going to be horrible for the patient. It's very cellular. And then you can see inflammatory cells. You can see grunge and bung and all those in the background. The cells are all highly atypical. Some are long with tails. Some have some eccentric or pushed side nuclei. And then you see the inflammatory cells at mix. They are in streaming pattern. Next slide. Close up, you can see the all the blood. And then the blood breakdown, blood products. You see this huge, horrible large cells there. 1, 2, and look at the third cell. These are overlapping, crowding. All the signs of malignancy are there. What do you think? Okay, next slide. Oh, this is huge. Look at the nucleoli inside too. Look at the nucleoli inside the dirty background. This is benign or malignant? Oh, everybody can answer that. Yeah. Pass. Yeah. Next slide, please. So you've got this, the background, the single cells, and then you have, I think that's a meso at the background as well. And look at the No, sorry. And then you can see the neutrophils there in the background. Very nice. Come on. Pap is showing the same thing. It's really ugly cells. Yeah. I think Arin is going wild with the pictures. There are so many beautiful pictures. Okay, next slide. See, she's enjoying the taking pictures. Look at all the ugly cells. And then I'm seeing the glandular, trying to do a poor attempt at gland formation. Little clusters and like this kid is trying to form a gland. Okay, come on, next slide. Your diagnosis. Is it malignant? Yes. Adeno, squamous, lymphoma, melanoma. What do you think? Squamous. Okay. It's the same category. Next slide. Where it's malignant. You can't say suspicious. You have to go all out. Malignant cells, they are cellular, they are in sheets, they are spindle, ovoid, nuclear cytoplasmic ratio is high, they are pleomorphic, chromatin is very coarse, you have large nucleoli, cytoplasm is pale, they are binucleated cells, the background has necrotic grunge. Okay, next slide. It's a malignant spindle cell neoplasm. That's a malignant. Yeah. So we call it a sky blue. Malignant non-small cell lung cancer. No, I don't think it's squamous. Slide. So differential diagnosis is it's polydifferentiated. Is it primary lung or metastatic? I don't think it looks mesothelioma. I don't think it looks melanoma. Don't think it's sarcoma. For me, I think I will go with the first one, polydifferentiated carcinoma, primary or lung cell lymphoma. Okay. So further, you can do cell block, and then you can do the following immunos. If for the lung, CK7, TTF1, and napsin A. Metastatic carcinomas, you do CK20 for the lower GI tract, and GATA3 to exclude breast and urothelial. I don't think it looks mesothelial as well, but then you can do these for HNV1, CK5-6. But then I think she is just putting it so that for completeness and what type of immunos would be good for cell block. Next slide. Oh, beautiful. So I'm sure. So I think this is for an exam, how to do the exam. So if you're going to do exam, you have to know this. I think you will get I'm going to leave the lectures so that you don't have to copy this. You can have the lectures. Next slide. So, and the lung, this case was resected, and you have these. That's why she's called it the spindle cell, I think. Other resection, yeah. Okay. And next slide. So span cytokeratin was positive. CK7 was highly positive. So immunohistochemistry was CK7, pan-cytokeratin A1-3 positive. But then the rep TTF1 and napsin A are negative. So it's polydifferentiated. Spindle cell is also TTF1 negative. Okay, so Next slide. So high-grade spindle, pleomorphic spindle cell tumor, pleomorphic carcinoma, non-spherical square. And it's a rare and it's an aggressive neoplasm. Beautiful though. Molecular testing, you can do this for cell block for treatment purposes as well.
Hopefully we have 67. Yeah, one, 68, three, 5, 6, and also we have yeah, we also have a and one, yeah, already, yeah. Not PGMR.
Okay. So 54-year-old female, cutaneous lesion right axilla. So they have no idea what is it. Is it an inflammatory process or is it a neoplasm? Okay. So what do you see? Come on, let's do it for the little ones. Little ones. Stop. Test sample. I like that. Yeah. So first you can see when you have a smear. So you can see the color looks like Dr. Tran's color coat. Yeah. So is it cellular or not cellular? It's cellular. Good. So what are you seeing there? Do you see cells or not cells? You see, you see dirty background. You have to look at the cells and the background. But if you look at the cells, this is what Dr. Tran was trying to say, that the cytoplasm is really dense, right? So this is not a clear cytoplasm, very blue, very blue. This is the sky blue, sky blue color. And then do you see there is no nuclei on that, then they are stuck to each other. And then when you come down here, have a multinucleated giant cell. There, yeah. Yeah, it's a multinucleated giant cell. It's a foreign body type of giant cells. You got the neutrophils, you got the inflammatory. What type of cells do you think these are? Inflammation, very good. That's it. The background is inflammatory. But what are the epithelial cells? What do they look like? Do they look like it's come from the ducts? They come from the glands? They come from the epithelium? It comes from the skin? It comes from, where does it come from? Ooh, no, it doesn't look like signet ring. So signet ring cells, you will have to have the dense cytoplasm. Okay, more pictures. Good. Yeah, more pictures. Okay. Yes. Some of them have some nuclei. This have nuclei. Look at this. This has no nuclei. This has no nuclei. This has no nuclei. This is, and then the color is, this is really, okay, you can see the multinucleated giant cells. It's an inflammatory process going on. You have it's inflammatory, there's suppuration, there's pus there. And then you've got this really anucleate cells. You call it nucleate because there's no nuclei. You cannot speak on the phone with your girlfriend. Okay, you too. Yes, you have three options. You can ask your friend. Okay. Or you can ask the two specialists in front. Who do you want to ask? You want to ask Dr. Anita Moljono, or you want to ask Professor Napaki? You can call a friend. Which is your friend? Who do you want to ask? Or you want to do the exam, the diagnosis yourself? Ask for more. So you can sebaceous gland. Okay, ooh, very close in nearby. So sebaceous gland, sebaceous is a surgical term. See, for us, for the pathologists, we call this an epidermal cyst, not a sebaceous cyst. Okay, so very good. What's your name?
My name is Me.
Name for the right answer. Very good. So you've got this anucleate squames. Okay, one next slide. Well, look, this is what we call the orangeophilia. It looks orange. It's look like that orange, reddish, yellowish, orange color. So it's an orangeophilia. When you have dense cytoplasm with orangeophilia, it comes from the epidermis or the squamous cells. So this is squamous cells. So is it benign or malignant squamous cells? More slide, please. So you look at the multinucleated giant cells, and there's a very dirty background. Multinucleated giant cells attacking the squames with inflammatory cells. Okay, benign or malignant? Benign. Okay, there's some said benign. Come on, next slide. Ooh, is it? Look at this. See, when you see this, you worry, right? This is a really atypical cell with a tail. Okay, and then it's looked like a tennis racket as well. Okay, but this is one cell only. We have to look for more. So you've got these really atypical cells. If you see this cell, a lot of these cells, you have to worry, but you only have one. It's a pyknotic cell. Come on, more. So you all think it's benign. You still think someone think malignant there or atypical? Okay, next slide. So it's benign. It's a ruptured epidermal cyst with associated subduration and granulomatous inflammation. Go on. So yes, plenty of anucleate squames and reactive superficial cells, multinucleate cells, neutrophils, macrophages, no malignant cells. Okay, if the reactive atypical cells have no malignant cells. Next slide. Ruptured epidermal cyst, which is also called, like I said, a sebaceous cyst. Slide. You can do a cell block. Next slide. Next case, case 5. 81-year-old male with hematuria. When you see hematuria in an old man, you have to worry now. What do you see? So, come on, tell me what you see. So let's, the young one can do it.
Things master of that we
We are in groups. And then you can see they are very dark cells. And you can see the contaminant squames or that, and some inflammatory cells. More slides, please. Next slide. So in single cells, it looks really horrible there. Look at this huge big cell. So really, it's trinucleated. This is very, very atypical cell. When you have this, is it benign, atypical, or malignant? Is it diagnostic? Yes. It's diagnostic. It is. Is it atypical? Or is it suspicious? Or is it malignant? Atypical. Atypical. Do you want to go a little bit more? Higher, more, or a little bit more? If you see that cell, the membrane, the nuclear cytoplasmic ratio is really wrong. It could not be just atypical. So it is either you say it's suspicious for high-grade urothelial carcinoma, or it is high-grade urothelial carcinoma. Okay, next slide. This is how you write the report. It's atypical urothelial cells. The background is inflammatory cells and red blood cells. But the patient is bleeding as well. Okay. But it was a bladder biopsy, and you can see that there are these highly atypical urothelial cells floating in the background. So we can't properly see the fibrovascular core. It's I think it's flat. Next slide. So you can see here is urothelial carcinoma in situ. You can see on the top lining urothelium is malignant. Next slide. So if you say high-grade urothelial carcinoma in the urine, it's the risk of malignancy is more than 90%. And then the patient will go immediately for cystoscopy, and Bào. Case 6, right pleural fluid. You have 10 mils, 100 mils of blood-stained fluid from the right pleural cavity. Okay, to your turn.
Cellular. Look like plasmacytoid cell. I can see some cells is cohesive, like cluster, and also the single cell. The background, we can see some small lymphocytes. Think of the tissues for malignancy.
Balls and clusters, and then it's this is very suspicious to outright malignant. So what can you do? Okay, more. Yeah, so you can see this huge atypical or malignant clusters of cells. I'm going to, for me, I can go. Yes, I'm not stopping at because you got this mesos here, yeah. But then mesothelial cells have, look here, you have windows and they wear skirts. I like the way they wear it. Meso, this is meso, but then you get this really huge balls, and this is, oh, that is malignant cells. Okay, next slide. PEP is very dark, so not very sure. Okay, but this is very good too. See, if you see all these very dark hyperchromatic cells that are lining up, I think this looks like trying to form a gland. And then you have nucleoli in this. Malignant cells, single cells as well. Yep, next slide. Ooh, multinucleated, but these are malignant multinucleated cells. Diagnosis is, go on. It's malignant. You have to go all right malignant. So then you have to do an ancillary test to make sure that it is what type of malignancy. Can you have the next slide? So can you have the next slide? So it is differential diagnosis is it metastatic adenocarcinoma or mesothelioma? So we need to have immunos done from the cell block. And you can do mesothelioma, you can do CK5/6, calretinine, and D240. And adeno, you can do all this. But then I think you should stop at whether it's meso or adeno first. So Claudin 4C and MOC13, I think is enough. Or if you don't want to use MOC31, you can do PEP4. We will wait the Gata 3, ERTTF1 and absent later. The second panel. Okay, can I have the next slide, please? So you can do all this. And next slide. So this is the cell block, and you can see these malignant cells in clusters. Next slide. And this is Gata3 positive. No, it's beautifully positive. So what do you think this is from? Gata3 is positive. What do you want more, or what do you think this is from? It's a woman. Okay, so what do you want more? You want? Okay. So Mark 31 is positive. So this is adeno, not meso. And then Gata3 is positive. Yeah, Claudin 1 is positive. So this is saying adeno. And then it is Gata3. Okay, next slide. So this is known history of metastatic breast cancer. Malignant fluid, yeah, in keeping with metastatic. So can we go to the next slide? We discussed this already.
Okay, Professor. At first, I would like to thank you for your presentation this morning because we also have this afternoon section. So I think we have to stop the presentation for this morning. We would like to invite to all of you to have this lunch in our department. And after that, we will come back to our afternoon section at 1 o'clock this afternoon. Yes. In this afternoon, we would like to welcome to Dr. Kim Chen to present about her pathology in breast and lung cancer on biopsy. Xin chào tất cả mọi người. Thì chúng ta sẽ bắt đầu cái phiên buổi chiều nay. Xin lỗi là chúng ta bắt đầu hơi muộn một chút so với lại thời gian quy định. Thì đầu tiên thì xin phép được giới thiệu tất cả mọi người là bác sĩ Kim Trần. Bác sĩ là xin được phép được một rất là tự hào khi mà giới thiệu bác sĩ Kim Trần. Bác sĩ là người Việt Nam đầu tiên trở thành giải phẫu bệnh ở nước Úc và hiện tại là đang là đồng giám khảo của một trong những kỳ thi quan trọng ở nước Úc là ACSMOS. Xin được phép giới thiệu tới bác sĩ tất cả mọi người hôm nay là bác sĩ Kim Trần, và bài giảng của hôm nay của bác sĩ sẽ giới thiệu tất cả mọi người hôm nay đó sẽ là các bước tiếp cận tới các cái mẫu sinh thiết của phổi cũng như là mẫu sinh thiết của vú.
Hi, thanks. Before I start, can I just say a few words? First of all, I would like to thank my friend, my colleague, and my mentor, Professor Esther Min, for organizing this wonderful workshop. And my friend, my newly made friends, or my old friends, Saba and Anita, for coming. And it's really, really a very enjoyable trip occasion so far. And nói một vài tiếng Việt nha. Kim sinh ra lớn lên ở Việt Nam, quận 5 đấy. Kim đi học ở trường, còn nhớ là trường sư phạm thực hành ở đường Trần Bình Trọng. Nhưng mà cái đó là 30-40 năm về trước, rất là già rồi. Từ ngày sang Úc thì Kim sống và lớn lên là học ở bên Úc. Cho nên tiếng Việt thì có thể nói conversational, nhưng mà những từ ngữ tiếng Anh, những từ ngữ medical term thì Kim phải dùng tiếng Anh. Nhưng mà tất cả mọi người có thể hỏi lúc nào cũng được. Kim sẽ cố gắng trả lời. And so Kim train tại University of New South Wales. Lúc đó thì lúc mà Kim học đại học thì chỉ có 3-4 người Việt Nam. Nhưng mà khi Kim tốt nghiệp Pathology thì Kim có một ngày hôm đó Kim làm frozen section thì gặp một cái anh surgeon. Anh đó là người Việt, cho nên anh đó mới nói với Kim là you are the first Vietnamese pathologist. So Kim suddenly nghĩ là mình là người đầu tiên. Mà lúc mà mình qua bên Úc thì mình không có nói tiếng Việt, nó không có nói tiếng Anh được, chỉ nói tiếng Việt. Tại vì mình đi học trường high school đó, cho nên nhưng mà bây giờ thì tiếng Việt của mình rất là giỏi. Có thể hát vài bản như là đời tôi cô đơn. Yeah, okay. So let's just start. So go back to English, yeah. So the first lecture, I'll try to make it really quick and give you some practical points. So I work at St.Geogre Hospital, which is one of the teaching hospitals of New South Wales Uni. And 80% and 20% of my time, I work with my colleagues here from Douglas Henley Moy, doing skin pathology. But other days at St.Geogre, we are, as a teaching hospital, get general specimen. A lot of them lung, core, breast core, just GIT, just everything general. Sorry, do I point somewhere? Oh, okay. Next slide, like you. So just a summary of my talk. I thought I would go through briefly lung biopsy techniques that we do in Australia. A little bit about radiology, because in lung pathology, radiology is really very important. We can't work by ourselves without radiology. So lung pathology is very broad. So in a brief 30-40 minutes, it's really difficult to go into detail of everything about lung pathology. So I have chosen just 2 topics: the organizing pneumonia pattern and neuroendocrine tumors. Those are the common things that we see in everyday practice. And then I would like to share with you some of the cases that we have come across my desk, and these are all our own cases from our hospitals, my own and my colleagues. Copyright, copyright here. So lung biopsy techniques. In our hospital, we have percutaneous transthoracic lung biopsy. These are quite commonly done using a CT-guided needle biopsy through the chest wall. And then we have the, usually they're performed for peripheral lung lesion, because you can imagine if you have a needle right through to the chest wall, the peripheral lesions are easily accessible. So, and then we have transbronchial lung biopsy. These are performed for infiltrates or lesion within the lung tissue and adjacent to bronchial wall. So they use a flexible bronchoscope, just like endoscopes they put to the nose going down, and they use a forceps to go through the bronchial wall and take some biopsy. The biopsy contain bronchial mucosa, alveolar space, and occasional mesothelial line pleura. Now, there's a new form of biopsies called cryobiopsies, which I won't go in detail, but essentially these, they use the freezing tissue and removal tissue. They use nitrous oxide. So you get large pieces of tissue, and they are used for assess interstitial lung disease, and it's beyond the scope of my talk today, so we won't worry about that. And then the EBUS, using the endobronchial, the ultrasound technique, again, obtain the tissue. And then we have endobronchial biopsies, the sample lesion in the bronchial wall, so right inside. So they look through the scope and they see the lesion that's sitting inside the bronchial, the lumen, and they take the biopsy. And then we have the two other techniques, which the invasive procedure, the open lung biopsy, and those are reserved for cases where they can't obtain enough tissue for the usual method. They have to go surgically remove under GA anesthetic. And then the video-assisted thoracic surgery, and it's removal of tissue through the chest wall, and we don't do that in our hospital. So the common diagnosis that we get in small lung biopsies, of course, the malignant neoplasm are the most common things that the biopsy is done for. So those are the list of neoplasms we get. And then don't forget, sometimes unexpectedly good for the patient, we had benign things like hamartoma and some rare neoplasm. I mean, the sclerosing pneumocytoma, pneumocytoma is really an interesting lesion, and I still remember having made that diagnosis a year or so ago, and the surgeon couldn't believe it, but it was on a tiny biopsy, and it was difficult, a struggle, but yeah. Anyway, then we have the non-neoplastic, and it's the infection, the scar, organizing pneumonia, and of course, amyloidosis. Amyloidosis can present as a mass lesion in the lung, and they can sometimes be biopsy. We had a recent case. It's really good. I would like my registrar to present it at some stage. So how do we handle lung biopsy in our department? We receive these core biopsies, either fresh or fixed in formalin. The fresh sample can be divided for microbiology or flow cytometry, depending on the clinical situation. In our laboratory, our protocols is we have 18 ribbons. So these are cut at 4 micron thick, so pretty thin. And we stain ribbons 1, 9, and 18. And the rest are spares. We put on immunohistochemistry stain slides. They are spare slides. So essentially, when pathologists receive that sample, they said they want to do XYZ immunostain. The slides are there, so we could actually proceed and get immunostain within the day. And lung panel immunohistochemistry stains are also done. And then we send for molecular studies. So we are, like Saba was mentioned before, we're really very conscious of the preserving tissue for molecular studies and immunostain for molecular studies. So on molecular testing, just a brief note, because my lecture is not about molecular, I'm an AP person. So we do routine lung panel immunohistochemistry stain on adenocarcinoma and non-small cell. So the stain, the 3 things that we do in our lab are PD-L1, ALK, and ROS1. It's actually, people think that it's not essential, but I still remember vividly a recent case that I had. A young lady in her 30s who came into the hospital was very sick. She couldn't breathe. And she couldn't have a lung core biopsy. But what she did have, when I discovered on the chest X-ray, was she had a massive pleural effusion. And on the pleural effusion, I think she was only 35 or 36, and she has malignant glands. So, and she was very sick in hospital, in ICU. You can see that's how sick it was. So urgently, because in our hospital, there's only a few pathologists, myself included, who can read PD-L1, the ALK, and ROS, because we have to be, there's quality assurance. Not everyone can read these things. So I remember being asked to stay back late to read this for her, because it makes a lot of difference to her treatment. So her ALK was positive on the cell block material. And it was on a Wednesday. I remember very well, because Wednesday, the next day was my last day. I have to work somewhere else. So I stayed really late to read. And the technician will very kindly did the stain for me to read. And it was a rainy day, and the the oncologist actually didn't wait for the NGS panel, gave her the medicine. And 2 days later, she walked out of ICU. So that was success story. So we tissue from paraffin block, we send for molecular testing. And like we said, we don't do it at our hospital. We sent to another reference hospital that does the NGS. And we did these, usually the standard are EGFR, KRAS, BRAF, and ALK and ROS and MET14. So for squamous cell carcinoma, we only do PD-L1. We don't do all the others. And for small cell neuroendocrine carcinoma, molecular testing is usually not required. So it's mainly for adeno and non-small cell. So the radiology. Now, I do MDT lung meeting, and pathology play an important part in lung MDT, multidisciplinary meeting, but radiology is really, really important. So a chest X-ray, CT scan, and a PET CT scan. So what the PET scan is actually, as you know, is a positron emission tomography with a CT scan in one machine. And it's actually very produce colorful images. And I'm so excited because I managed to download some of these images during my meeting and to show you some of the cases a bit later. So they used to locate lung and stage tumor, and then SUV score, which is FDV avid, anything greater than 2 is suggestive of malignancy. But of course, there's false positive, you know, inflammatory can be high FDG avid. So now moving on to organizing pneumonia. Organizing pneumonia pattern is at a biopsy, core biopsy done when the patient has an area of consolidation or a lung lesion. Now, this is important to recognize them because not to overcall them as malignancy. So what it is, the classification is the finding of polypoid blood or loose connective tissue in alveolar space, remembering the alveolar or alveolar space. So these fibrous blood, they originate in the interstitium and they move into the alveolar space. Now they're different from the UIP or usual interstitial pneumonia because in those cases, these fibroblastic foci are actually located in the interstitium. So they have, in UIP, as you know, you have these fibroblastic foci and then normal lung and then these fibroblastic foci. So there is a difference in appearance. Why is it important to recognize this pattern? Because first of all, you don't want to overdiagnose. And secondly, these cases can be seen adjacent to a neoplastic process. So you have to be sure that the biopsy actually goes into the lesion and have to be representative. So just to demonstrate a case, I have a 68-year-old male with a left pleural base mass in upper and lower lobe. And it's FDG avid, SUV of 8.5, it's quite high. He has a history of pulmonary embolism and they suspect it's cancer. So they did a biopsy. So here it is. Very proud of myself. I managed to download this in my technically, I'm really bad at technical aspect of everything, being old, you know. But anyway, here it is. You can see this is a PET scan. You can see that little round thing there. So it's a left lower lobe, and looking at the color on the left-hand side, you can see it's kind of middle. So it is a bit hot, you know. And then the CT biopsy, it's upside down. You can see that's the thoracic spine over here. And you can see the needle go right into that lesion over there. So we know that the biopsy is representative from radiology. So what do we get? So we get a core biopsy that shows really consolidated. There's no lung space here. There's just no air space at low power view. And then on higher power view, you can see, apart from the inflammatory cell in the background, you can see these loose fibrosing. It's just really hard to have that stop sign to show. But those one, can you see? Those fibroblastic foci, these are classic picture of organizing pneumonia. So a higher power view, in this case, there are, again, these fibroblastic foci. You can see those little, almost like stromal fragment you can see in cytology, and then inflammatory background, and then multinucleated histiocytes, and some of them are sort of like ill-defined granuloma right there. So at the meeting, the clinician was saying, are we sure? Are we sure this is not malignant? And it looks really like a solid lesion on the CT and the PET. So just for interest, I would like to demonstrate with you the TTF1 and the cytokeratin staining that I know you have in your department. And here it is, the TTF1 staining shows these are positive pneumocytes, type 2 pneumocytes lining the alveolar space. And then, so there are a lot of them, but the architecture is still the same. They're not disorganized, they're not grounded. And the cytokeratin similarly the same. Demonstrate that. See that the fibroblastic plaques actually inside the lumen of these alveolar space. So the diagnosis, so I said to the clinician, this is organizing pneumonia. If you are sure that the needle is right in the lesion, this is benign. And then we did fungal and acid-fast bacilli stain. So our ZN and PAS were negative because of the granulomas. And of course, any inflammatory lesion, you should always do those stains. And following a lot more discussion, we decided this is aspiration pneumonia and he's fine. So go home, no worries, it will resolve. Okay, next case. So we have another lady of a 36-year-old lady with an incidental finding of a 21 millimeters right lung mass. She has a history of lupus, and clinically, again, they suspect is malignancy. She's a young lady. So they decide to take the biopsy. So anyway, chest X-ray, you can see my arrow right there, my blue arrow that showed that little mass right there on the lung. And then on the CT scan, there's a mass right there. There. This arrow is not very good, isn't it? A point is a lot better. Okay. So the biopsy was done. So what do we see? We see again a core biopsy. We're doing core here. So core biopsy. Yeah, consolidation right there with inflammatory cells, and on high power, these little unifying granulomas. And within it, you can see these little budding yeast organism. Can you see that? So the clinician was very excited. I can't believe this is benign. Oh, it's got to be malignant, surely. And we say, no, she is a benign. So we did lots of stain. We did the PAS stain. You can see the organism. Can you see the little round thing there? And then on the growth, which is a silver stain, the little round thing. So she has Cryptococcus infection. Now they want to know what type of Cryptococcus it is, because we can't believe it's Cryptococcus. So we have to send to Westmead, another bigger hospital, for PCR. It turns out it is Cryptococcus. It's Cryptococcus, I think, was neoformans. I can't remember, but my colleague, Australian, said to me, these Cryptococcus actually, they grow in the trees in Australia, southern gum tree. So it's not because she's immunosuppressed. They are from the tree, and I believe him. I mean, he's Australian after all. Yeah. So next page. Now, so in core biopsy, we always face the challenge of make a decision whether reactive epithelial change or adenocarcinoma, and how do you deal with that? Now, can be quite difficult. You need a lung core biopsy, you need adequate material. You need to, can be very challenging on core biopsies, because these days, lung core biopsies can be the only diagnostic procedure that the patient has. They don't do excision, they don't do lobectomy unless they have to. So they treat the patient based on the core biopsy. We make the diagnosis. So low-grade and lapidic or adenocarcinoma in situ can lack invasion. And the usual useful features supporting the diagnosis Minimal, you can read, minimal cytological atypia, cuboidal cell, double. Now, the new thing that I find is useful is actually double layer epithelium. They have preserved basal layer in benign things. Sometimes if it's a solitary lesion, they call it adenoma, but in general, you can get preserved basal layer with you do P63 or P40, similar, and they lack nuclear overlapping, and they have regular nuclear contours, and also background stromal changes. So invasive thing, what we call have desmoplastic stroma, which is inflammatory fibrosis change in the background. It is very challenging, and I am not saying that easy, but if you have difficulty, always do serial sections and show to your colleagues. Don't be afraid to take the slide to your colleague and say, do you agree it's malignant? Because you take the pain now and go the right way. First of all, you do the patient service and you don't get sued. Because I have seen cases where benign diagnosis become malignant, and then lobectomy comes out, a lung comes out and no cancer, and it's really bad. Once it's out, you can't put it back in. So be very careful. It's not like skin. You only have 2 lungs. So the take-home message is organizing pneumonia and infection can present as a nodular solitary lesion, and you have to correlate with clinical finding. Again, be friend with a clinician is really good. If they don't believe it's benign and your biopsy say benign, they will pursue and repeat the biopsy. You got to put your foot down. You got to say, I think on this is benign, but if you think it's malignant, do another biopsy. You have to. And staining for TTF1 and cytokeratin 7 highlight the underlying lung parenchyma, but does not mean it's a neoplastic process. And then in equivocal cases, difficult cases, it's okay to say, I don't know. It's just best is atypical epithelial proliferation. And then correlate with their clinical, and they said, oh, we're still worrying, we're still suspicious, we would repeat the biopsy, get a better radiologist who can put a needle in. So just some example of what we call lipidic adenocarcinoma. So you can see here that's normal and that's abnormal. And the abnormal cells follow the alveolar structure. And here it is on high power view. You can see the cells are really low cytological atypia, but it's the pattern of infiltration that makes it lipidic. And then the external pattern of adenocarcinoma, that's clearly malignant cells right there. Just to show you the difference. And these are real cases from that we have. So the next sort of biggish topic I want to talk about is neuroendocrine tumor of the lung. The 20% of all lung tumors are actually neuroendocrine. It's important to recognize because the treatment is different. So with neuroendocrine tumors, the classification is as shown. So you have diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. It's really difficult to diagnose this on core biopsy because you need a bigger piece of tissue. So for all intentional purpose, they don't really exist in core biopsy. So pulmonary neuroendocrine tumorlets, so they go on size. And then we have typical, atypical carcinoid. In lung, it's about the only organ that carcinoid terminology is accepted. Everywhere else, they call it neuroendocrine tumors and grade them. And then we have small cell and large cell neuroendocrine. Did I just... Okay, so precursor lesions, the pulmonary tumorlets. So tumorlets are size, based on size. So they look like carcinoid, but they're small. They're less than 5 millimeters. They are planned neuroendocrine cells. And then the idiopathic pulmonary neuroendocrine cell hyperplasia, like I said, is just not possible to diagnose on core biopsies. And 50% of these precursor lesions will go on to develop typical carcinoid or atypical carcinoid. So the typical carcinoid, I'm sure you all have seen, is cytology, they're planned uniform cells forming all these various patterns, minimal cytological atypia, minimal mitotic figures, no necrosis, and they may infiltrate and the cartilage, and they may even metastasize, but on the classification, they are still carcinoid. And then, okay, so let's show you a case to demonstrate, just to wake you up. Now, this is a case I have recently, very recent, an 81-year-old who has a right lower lobe pulmonary nodule of 25 millimeters and SUV 14 on a PET scan. Now, this PET scan, can you see that red little nodule there? That's her lesion right there. And then incidentally, she has a little lesion on the right submandibular area right there. So at the MDT, the discussion was, so what do we do? If she only has one lesion on the lung, they can operate, because single lesion, operate, gone, finish, she's cured. But if she has, if that thing, right submandibular lesion, is a metastatic carcinoid, perhaps she has to be considered other treatment and cannot go for surgery. So what do we do? What do they do? So they did an FNA of the right lower lobe lesion. And you've had a cytology session, so you can see that the cells is very cellular smears, epithelial cells, very abundant. It's very mild nuclear atypia, abundant cytoplasm. And at this power, you can see the chromatin is kind of peppery, granular chromatin. So this is a classical appearance of low-grade neuroendocrine or carcinoid in the lung. So they also do lung biopsy for us. They're very generous at our hospital. They like to give us lots of tissue to make a diagnosis. So lung through multiple cores biopsy, this is the normal bronchomucosa here in the lung. So on high power view, these are epithelial cells forming all these cords, rosettes with the sort of edematous background. And in other areas, you can get spindle cells, so carcinoid, the lung core, there's hardly any mitosis or no necrosis. I know it's difficult to see at this power, but yeah, spindle cell. So immunostains, we know all about immunostains. We don't need that many immunostains for these things unless when they don't work. A low-grade lesion, they often work quite well. So synaptophysin positive, KM 5.2 positive, and TTF1 positive. In our department, the TTF1 nuclear staining have to be strong. They really have to be strong like that to be called positive, because sometimes you get a bit non-specific staining, a bit wishy-washy stain. So you have to know what kind of stain your department has. And the key 67, can you see it's really low, only a few nuclear staining, so low key 67. So this is a benign sort of low-grade neuroendocrine tumor or carcinoid. So, like I said, the clinician want to know, is it really carcinoid or is it a typical carcinoid? Why is she having this right submandibular gland lesion? So I said, no, on the core biopsy we have is a carcinoid. I can't tell if it's a typical carcinoid on the material I've got, and that is very difficult to make a diagnosis because you need to see necrosis and mitosis. And on what we have, the key 67 is really low. So they decide to go ahead and do right submandibular lymph node biopsy. And we got that too, I got that too. So the lymph node biopsy shows here the couple of core biopsies, very effaced architecture. You can see at low power, can you see that nodular sort of area there? And the other core is sort of diffuse, but on higher power view, difficult to see, but you can see that round nodular structure. This is a follicular structure of mixed cell types of small and intermediate cells. So immunostains, I try to be quick, so I squeeze everything on one slide. So the CD21 highlight the follicular structure. That's a stained dendritic cells. You can see follicular structures. It's diffuse staining for CD20, CD10 positive in the follicular center, BCL2 positive, and you can see BCL6 positive. So this lady has follicular lymphoma grade 2. So the treatment for follicular lymphoma grade 2 is the clinician said it's not terribly urgent. Hematology was consulted. They said she can wait. There's no thing. So they're going ahead and treat her with the carcinoma without surgery. Or there's still consideration. I don't know. It's only a recent case. because they thought it was metastatic carcinoid, they didn't send fresh, so we didn't have flow. So the take-home message here is more than one pathology can occur. You can't assume that because she has a primary lung lesion that the other is a metastatic disease. And a typical carcinoid is really difficult to on core biopsy because of the limit of material. So a typical carcinoid like I have described, Ki-67 here is 5 to 30%. So that's the key, the differential. So the next one is small cell carcinoma. And this is important to make this diagnosis because I remember when I was starting, finishing my registrar and become a consultant at St.Geogre Hospital, they often make us come in to make this diagnosis on cytology because these patients present with SVC obstruction. So they need to be treated urgently. So this is one of the cases. It's always Friday. It's always Friday. Can you make that diagnosis so we can give her steroid and, she can breathe. So, small cell carcinoma is 15% of lung carcinoma is diagnosed with associated with smoking. And these people they often are hilar region. They have small, medium cell size. Sometimes people say small cell, but the cells are actually not small. It's not the right terminology. The reason why it's called small because they have very little cytoplasm. The cytoplasms are very fragile, and when you smear or you take the section, all you see is a nucleus. So people think it's a small cell. But if you compare to the adjacent lymphocyte or red blood cell, they are actually a bit bigger. So their Ki-67 is really high, and they have a 90% of them are positive for TTF1, and the DD here is actually lymphoma. So I have a case.
Excuse me, Dr. Kim. Sorry to interrupt you.
Yeah.
I would like to introduce to all of you guys to our new principal of this university, Associate Professor Ngô Quốc Đạt. Okay, thank you, Professor Associate Professor Ngô Quốc Đạt, for being in here with us this afternoon session. So I would like to invite Dr. Kim to come back to your presentation. Thank you.
So everyone awake? That was a good, you should have stand up and stretch. Okay, so yeah, this case. I have a 64-year-old man who is a smoker. There's a lot of smoker in Australia, but yeah. So he has suffered from weight loss, and he has a left upper lobe mass with widening of the hilar region on chest X-ray. So they did a PET scan on him, and he really have extensive bony and mets and hilar node involvement. So all those dark black spots are all, his involvement. And on the beautiful PET scan again, you can see that little 2 lesions here with very, very hot. So the red is really hot in left upper lobe and hilar lymphadenopathy. So again, they did FNA of the hilar lymph node, and it shows really necrotic background with clumps of cells. These cells, again, if you remember what the carcinoid looked like, this is entirely different. There's hardly any cytoplasm. There's a lot of cell clumping, or what we call nuclear molding, where the nuclei are tied to each other. And the cells are sort of intermediate size. They're not really small because you compare to the background red blood cells, they're a little bit larger. So the red blood cells have constant diameter. From memory of my hematology day, probably 7-8 micron, and it's similar to lymphocytes. So these cells are a little bit bigger. So this is a malignant process. It has the chromosome look like neuroendocrine. So it's actually on cytology. This is small cell neural tumor. So if you do our cytology exam, we would expect you to come to some kind of diagnosis. So the biopsy, the EBUS biopsy of the lesion shows again similar because it's EBUS, so we don't get the architecture because it's just a bronchoscopy. They did multiple biopsies. So it's a very cellular sample. These are the tumor cells. It shows exactly the same as what we get in cytology. And then there's a lot of necrosis in the background and lots of mitosis. These cells often are very fragile. So you can get epithelioid or spindle cells and crush, a lot of crush artifact. And sometimes they may look like lymphoma or lymphocyte, but be careful. They're not. So the cases like this, sometimes when you can't see very well because the biopsy maybe not so good like this, you should walk down to your cytology colleague and said what you get in the cytology, and you combine the cytology finding and your histology finding. Always get help. So the immunohistochemistry stains is helpful in this case. It demonstrates cytokeration Chem 5.2 staining. Now the Chem 5.2 staining in small cell is different from carcinoid, is that it's positive but weak. Quite weak staining. And you look closely, you can see little perinuclear dot. That signifies the neurosecretory, the secretory granules you see in the cytoplasm. So they give a little dot, but the staining is weak, but it's positive. And synaptophysin, sorry, difficult to make it very clear, but you can see the brown color is positive. And the TTF1, oh, I didn't say. TTF1, thought I forgot to label them. It means TTF1 is strongly positive, and the Ki67 is so high. This is really high. 80% here. So it's small cell carcinoma. Now, the large cell neuroendocrine carcinoma is not common. It's an aggressive tumor. The nuclear changes are also of neuroendocrine, but they're large and they have nucleoli. So that's the only difference. The difference is nucleoli, whereas the small cell don't have nucleoli. They are often associated with adenocarcinoma or SCC, and they have very high mitotic activity. And now, if there's a small cell carcinoma component present with the large cell, it's better to call combined small and large cell, because the small cell carcinoma can be treated. They treat it with chemo, not surgical treatment. So the small cell component is more important. So the immunostain, like we said before, now just highlight the CD56. CD56 is positive in neuroendocrine tumor, but it's very non-specific. It's staying positive in a lot of things. So personally, I don't like to use unless I have nothing else, unless sometimes something that looks like neuroendocrine small cell, but synaptophysin negative, chromogranin negative, TTF1 negative, and it does happen. So in desperation, we do CD56. And also remember, TTF1 is positive in a lot of small cell lung cancer, but TTF1 can be positive even if those neuroendocrine tumor arise from non-lung sites. So it's not an and/or to everything. You have to assess clinically. So I managed to find an example of large cell neuroendocrine carcinoma that we have. And here you can see the cells are pretty large with, again, the neuroendocrine nuclear features and prominent nucleoli. They're large and high Ki67. And Chem, can you see the little dot, so quite prominent dot? I'm not very good with the arrow, but you can see the dot, yeah? Otherwise, just believe me. Take-home message on lung core biopsy. Like I said before, a lot of the lung non-small cell carcinoma is unresectable. So they need your diagnosis on the core biopsy to treat. They don't operate. So it's very important to get it right. Yes. So those cases that show TTF1 positive and P40 negative. So there's not many immunostain that you need for lung. So it look like epithelial origin cancer. You do TTF1 and P40. That's potentially the suggested immunostain. So 80% of lung adeno is TTF1 positive, except for mucinous lung adeno TTF1 negative. So those are straightforward. So you only need 2 stains. Now, strong diffuse P40 staining with negative TTF1 is SCC, or squamous cell carcinoma. diffuse TTF1 positive with focal positive P40, it still can be adenol because the P40 staining must be in the same cells that stain for TTF1. And rarely P40 can be positive in adenocarcinoma. And when do you diagnose adenosquamous carcinoma on lung biopsy? It is difficult, but you have to have two separate components. One positive for TTF1 and the other one positive for P40. So continue. If TTF1 positive, P40 focal, sometimes you can't tell. You have to say unclassifiable non-small cell lung cancer, so they can treat the same. Consider nut carcinoma. A nut is rare, and we have to send away. We think is the case, and usually it's rare. I haven't really come across a case myself. Now, in case of what if TTF1 negative and P40 is also negative? Now, this is a time when you really have to reconsider. Is it a carcinoma? You really have to go back and do your cytokerosene. And if it's solitary lung lesion and poorly differentiated, consider other things like melanoma, looking for some pigment. Sometimes you're lucky and you might get pigment in the cell, and that's really helpful. Or lymphoma, if cytokerosene is negative. Or spindle cell. Those spindle cells are chromatoid carcinoma. So you might have to do a few cytokerosene to get something stained. So in WHO definition, the term large cell carcinoma is, as a diagnosis, is not made on a small biopsy. It refers to the resected specimen. So it's better called non-small cell carcinoma. So just a brief word on TTF1. People think, oh, TTF1 is really the answer to primary lung adenocarcinoma, but it's not. It's different clones of TTF1. So like you need to know what the clone that is used in your laboratory. So I know in my laboratory is SPT24. And then this clone in my laboratory is sensitive, but it's not specific. So sensitive means it can stain for a lot of things, a lot more things can be stained. So you have to assess what is considered to be positive in your laboratory TTF1. And 80% of lung adenocarcinoma is TTF1 positive, but the other 20% is negative. So, and TTF1 is positive in other tumors such as thyroid, some colorectal cancer, some gynae cancer, some breast, and even mesothelioma. And then, so we have Nepsin A, and people said, okay, Nepsin A, very helpful. But as you know, Nepsin A is positive in TTF1 positive. So when you already have an adenol with clearly glandular differentiation, TTF1 positive, if you do Nepsin A, most of the time they will be positive. So in the poorly differentiated tumor, Nepsin A is often not helpful. And Nepsin A, as you know, can be positive in clear cell cancer of the gynae, the ovarian cancer. But there are some tumors up to 10% of the time, Nepsin A can be positive. And I will demonstrate a little bit later in one of my cases. So just to show you an example of some of the typical lung tumor that we get. So basically, squamous cell carcinoma, non-keratinizing, CK56 is positive, P40 very positive. P63 can show similar things, but P63 is, they say it's a little bit less specific. P40 is more specific. Now, if you have a lung tumor and you said this person has SCC, does that mean, and then the patient, the clinician said, oh, but he has an esophageal mass. Now, can you, you can't be certain that that is not metastatic esophageal SCC, because SCC anywhere in the body look like SCC. So you can't tell on histology alone. And skin SCC, head and neck SCC can metastasize to the lung. So you really need to have a clinical background and a clinical story before you can say, yep, there's no other primary. This is primary SCC of the lung. This adenocarcinoma, I mean, I have managed to educate my clinician that SCC anywhere look like SCC. So don't ask me, you know, could it be from here? Could it be from there? You know, it's the same. Adenocarcinoma, the typical, and that's our TTF1 in our laboratory. That's how we see the positive cell. So now let's show a few cases, short ones, and then we finish. See, I know it's very fast. Now I have sorry? It's okay? Yeah. So I know it's good to learn from cases because theory is always above my head. You know, I'm not a theory person. I'm picture. I like pictures. That's how I do pathology. It's for the pictures, for the color. I can't imagine the radiologists, you know, so boring, all these black and white photos. I can't do it. I know the PET, but PET is nuclear medicine. It's different. Yeah, it's not radiology, you know. So yeah, I can't stomach black and white photos. Yeah. So we have a 74-year-old man, a smoker, left lower lobe lung mass, single lesion with high FDG. But we got a history. He has a left kidney, his kidney was removed a while ago. I don't know when, probably a few years back. But we got that history, and it's really good. We have the history. So lung biopsy was taken. Before lung biopsy, of course, we have radiology, very important. So you can see the mass on the here. See that mass and the mass. See the color. See the color is big at all. I don't really need to point. You can see that big mass there with the bright PET scan. So lung biopsy, very exciting. So this is a core biopsy of the lung. You can see here cartilaginous tissue, some bronchial wall here, cartilaginous tissue, and this tiny lesion. So we mark it for you to see that's how small it is. And we have to do, I don't mind telling you, we have to do serial section, 24 serial section at, 4 micron to get to this big. Before it was only a few funny atypical cells. And that's how we do. And we save every single, we don't do levels because the difference is when you do level, you cut in between, they throw it away. But when you ask them to do serial section, they save everything. So when they save everything, we use it for immunostains because you can go back and say that level, it's got the tumor. Let's do the immuno next to it. So our immunostain, at higher power view, you can see a bit clearer. Can you make out this cellular lesion with some are clear cytoplasm, and it's kind of a busy looking thing. It's metastatic tumor in the lung. It's not like you get in the primary lesion. It doesn't always look exactly the same. It always looks a little bit, fuzzy, a little bit vague. You have to think about it. And yeah, that's what we do, Otherwise, they don't need us anymore. Okay, so we do some stain. Now, again, be selective what you do. So we have cytokerosin. You can see here, that's cytokerosin positive. PEX8. You guys have PEX8? I don't know. You have PEX8? Yeah, it's really good stain. And TTF1, you can see the TTF1. You can see a few cells positive. That's non-specific staining, very weak positive staining, and CD10. So this is metastatic clear cell renal cell carcinoma on a small core. Next page. Okay, so this is an interesting thing that we get all the time. This mucinous lesion. So we have an 80-year-old man who has left upper lobe lesion. I don't think I've got a radiology for this, but so you can see, can you see that that's the lesion is actually a mucinous and it's low grade looking. So all the cells are lying at the bottom and the mucin are sitting on the top. All these mucin push the nuclei down the bottom. So this is a low grade looking. Because high grade mucinous, you probably won't be able to tell it's mucinous, it's different. So low grade, but it's invasive. So cytokerosin 7 positive, CK20 negative, TTF1. Again, can you see a few cells positive staining? So you can get some positive staining, but it's not overwhelming. So how do we approach these cases? We said it's mucinous adenocarcinoma, but can we be sure it's primary lung? We can't. We need clinical because pancreatic adenocarcinoma, pancreatic upper GI, mucinous can look similar. They can be CK7 positive, CK20 negative. So in that case, many times I have thrown it back to the clinician and I said, you have to investigate the upper GI tract. You have to investigate whether the patient has a pancreatic biliary tract lesion or not. And sometimes we strike it, we correct. Sometimes there was a pancreatic lesion that they didn't find out before, because the pancreatic lesion, they don't give symptoms until it's big. So the patient don't present with abdominal pain. They present with a lung mass, I mean, cough and shortness of breath and all that. So it's important. So what do we tell them? We tell them that, oh, I need to take this slide, it's double up. Anyway, lung is often negative for TTF1. Mucinous adeno, negative TTF1, acceptable. So we have to exclude adenocarcinoma from other sites of the body. And positive staining cytokerosin 20 is seen in lower, usually lower GI tract. So I have a case to demonstrate that. So we get a lot of lung core biopsy. So within a week or so, we have another case of a 75-year-old male who has a right lower lobe mass, and they take the biopsy. So that is cartilaginous tissue. So we know we're in the lung, and this is the tumor. So this tumor is cribriform. It's got necrosis in the background. So it's adenocarcinoma. So what do? We look at the history. They didn't give it to us. So we have, usually sometimes we have to go and search. I mean, we have to do some stain. Of course, we did TTF1 and it's negative, completely negative. We did CK7. Usually if you need to do cytokerosin, do 2, do 7 and 20. It's helpful. So 7 negative and 20 positive. So we ring up the clinician and we said, is there a history of colorectal cancer? And they say yes. So it is metastatic colorectal cancer. And sometimes the lung core biopsy, colorectal cancer can look like colorectal, but it may not look like colorectal. And some primary lung tumor can look just like colorectal cancer, like micropapillary variant, whatever. So clinical history, very, very important. Another case, I think maybe it could be my very last case, because this is a very good case that I'm saving up and I really like to show. This is a 76-year-old lady with a chronic cough, and the chest X-ray show widening of the right hilum. Can you see the hilum is widened here? There's a shadow here on the chest X-ray. And if you look at compared to normal chest X-ray, it shouldn't be there, that thing. Now, there was a CT scan, but I have difficulty downloading and anyway, so I'll do with just demonstrate with a chest X-ray. So an e-bus biopsy was done because it's a right hilum mass. So they did a bronchoscopy and they biopsy them. So on the e-bus biopsy, you can see, can everyone see this is bronchomucosa, ciliated, and then this tumor is sitting right next to it. So it's ulcerated right into the bronchomucosa. It's very poorly differentiated. These are the mucinous glands of the bronchial region. So the tumor is solid, but you can see there's some glands here. So so how do we approach this kind of thing? So we did some immunostain because it's poorly differentiated large cell carcinoma and with possibly some glandular formation. So we did cytokerosin. You can see the cytokerosin KM 5.2 is positive. That is a normal bronchomucosa, and that is positive. And TTF1 shows is negative in the tumor, but positive in the bronchomucosa. So that is a positive control. I mean, a good internal control. We did P40, and it showed just a few cells positive, nothing to talk about. Most of the cells are negative, but somehow it's a woman. So we thought, oh, it's a bit unusual. So we cheat a little bit. We ring up clinician and we said, what's the story with this lady? Does she have anything in the past? And they said, oh, 5-6 years ago, she has a hysterectomy. She has an endometrial cancer. So there it is. We did ER positive. and PGS-8 positive. So this is metastatic endometrioid cancer that is not that common actually that goes to the lung. I mean, we had only a few, not common. Yeah. No, yeah. Yeah. Right, yeah. We didn't think of it because I mean I didn't take a very high power photo, but on high power these actually are not neuroendocrine looking. They actually they large you know I like low power stuff, so I didn't take any photo of the high power view, but they didn't look like, they didn't have the cos peppery chromosomes that we get in the typical neuroendocrine. So yeah. Yeah. No. Yeah, no, PGS-8, it was very good. So that's one use of PGS-8. I think, yes. So with the clinical history is always very important. Unless you have a primary a tumor somewhere else, you have to prove that it's not metastatic before you say this is primary lung. And urology, urothelial carcinoma, I have seen quite a few that actually go to the lung. When I was preparing this talk, I couldn't dig it out because I have so many, and you know, after present a meeting and they just gone. So, but I do know that urothelial carcinoma is one cancer that can go to the lung, and they are of course GETA3 positive and P63 positive. Oh, I meant to show you another case that I just had a few days ago, was shown to me. It's adenocarcinoma of the lung with papillary area. And the nuclei is a bit overlapping. It's in fact metastatic papillary carcinoma of the thyroid. And I think I put it in maybe another version of my talk and it's not here. So anyway, how to distinguish from that is PGS-8 again. PGS-8 is very important because TTF1 is positive in primary lung and metastatic papillary carcinoma of thyroid, because the name is the TTF1, is thyroid transcription factor. So you use PGS-8. PGS-8 will help to differentiate between metastatic papillary carcinoma from thyroid and lung adenocarcinoma. So thank you. And this is a picture from recently from my backyard. The flowers is typical. We just finished a season of Clivis in Australia. And now the flowers are gone. I have to go home and prune the leaves. Thank you, Tatian.
Thank you, Dr. Kim Jun, for your wonderful presentation. So I would like to give a summary for your presentation. Yes, in Vietnamese version. Thì xin phép được gửi tới tất cả mọi người một cái bản tóm tắt nho nhỏ thông qua cái bài báo cáo của bác sĩ Kim Trần. Thì chúng ta sẽ có nhiều phương pháp sinh thiết khác nhau, và bác sĩ Kim Trần đặc biệt nhấn mạnh việc kết hợp giữa các yếu tố lâm sàng, hình ảnh học và mô bệnh học để đưa ra một chẩn đoán quyết định sau cùng. Trong các trường hợp của sinh thiết phổi, chúng ta nên cân nhắc việc tiếp cận mô bằng việc cắt sẵn các slide liên tiếp. Đây là một trong những điểm vô cùng quan trọng để có thể đảm bảo việc đủ mẫu cho các xét nghiệm bổ trợ sau đó. Các trường hợp viêm phổi tổ chức hóa có thể nhầm lẫn với các tổn thương ác tính trên lâm sàng. Do đó, việc đánh giá các cấu trúc tuyến còn nguyên vẹn, không tăng số lượng cũng như là việc xen lẫn với các mô đệm thâm nhập tế bào viêm và mô đệm sợi tăng sinh là những điểm chính. Ngoài ra có thể sử dụng TTF1 và CK7 để làm nổi bật các tế bào biểu mô, sẽ giúp cho việc đánh giá chính xác hơn. Các trường hợp cần phải chẩn đoán phân biệt giữa tế bào biểu mô phản ứng với carcinoma tuyến, cần đánh giá các địa điểm cấu trúc như thay đổi mô đệm, các số lượng tế bào lớp biểu mô, hoặc là thay đổi các đặc điểm tế bào như là tỷ lệ nhân, bào tương, các đặc điểm lông chuyển, mức độ chồng chất tế bào cũng như đặc điểm màng nhân là các yếu tố quan trọng cần phải đánh giá. Khi sử dụng các hóa mô miễn dịch ở trong ung thư phổi, thật ra thì chỉ có sử dụng một số tương đối các dấu ấn có thể kể đến, chẳng hạn như là TTF1 đóng vai trò quan trọng trong việc chẩn đoán carcinoma tuyến của phổi, nhưng độ nhạy chỉ khoảng 80%. Ngoài ra cần phải lưu ý việc TTF1 có thể biểu hiện dương tính ở trong nhiều mô học ung thư cũng như là tổn thương lành tính khác nhau. Việc sử dụng B40 được cân nhắc tốt hơn so với lại B63 vì có độ đặc hiệu cao hơn. Trong khi đó B63 có độ nhạy cao hơn, do đó sẽ dương tính với nhiều những cái tổn thương và cấu trúc khác. Và điểm cuối cùng mà chúng ta cần phải lưu ý đó chính là cần phải kết hợp giữa đặc điểm mô bệnh học với lại lâm sàng, cũng như là việc kết hợp với các dấu ấn hóa mô miễn dịch và cân nhắc các xét nghiệm sinh học phân tử để hỗ trợ và đưa ra quyết định điều trị đúng đắn nhất cho bệnh nhân. Xin cảm ơn tất cả mọi người.
And then too late to ask questions because we're supposed to know everything. No, we don't. Pathology is a continuing learning process. I'm still learning every day. I ask my registrar for new things. My molecular pathology is really bad. I really need a molecular pathology for the dummies. And I have learned so much from my young, pathology registrars who go through our department. And I learn from everyone. I learn from my colleagues. I really do. I mean, yeah. So don't be afraid to ask. And every question is important, and every question makes us think that, oh, we should have discussed about this, and it's important. Everyday practice is a learning process, you know.
So thank you, Dr. Kim Chen. So I have one question from the audience. Do the radiologist in your hospital uses the lung RAS classification, the lung RAS in X-ray?
I haven't seen them use in my lung MDT meeting. So I don't know if they're in their specialty discussion whether they use or not, but for us, they mainly concentrate on, because lung is the reason why they biopsy is for exclusion of tumor. So they don't even concentrate too hard on chest X-ray. They go straight to CT scan and PET scan. So PET scan plays a really important role in diagnosis lung tumors in our institution. And you can see it's very useful. I mean, it's good, actually quite good. I'm impressed. But you have to take it with a grain of salt, because positive PET scan does not always mean malignancy. As I have demonstrated, organizing pneumonia, anything inflammatory can be hot. Infection can be hot. So you have to interpret in, with the clinical context and histology. And be very, very confident in your histology. Don't let the clinician push you around. I'm actually very nice and approachable. So, and be in contact with your clinician. I mean, that's a really important, because it's a multidisciplinary team approach to treatment of these things. And yeah, it's good if they respect you and they trust what you say. Yeah, and if we said to them, we very readily said, look, you haven't sent us enough material. Go back and send us more. They don't argue because they know that we've done our best, you know? So, yeah. Anyway, breast biopsy. Let's change the topic. Lung, very depressing. Let's go breast. Yeah. Yeah. Yeah.
We don't know for vision, particularly for the lung vision. They use small houses quite often, even though for the Vietnam. But the big question for the practical, how to ensure they we have enough tissue, enough vision to make a diagnosis, because as you know, in Vietnam, all of the doctors diagnosis, but often they often decide for talking with other. So how to, yes, my question.
So, you know, the biopsy, I noticed over the years, it have been getting smaller and smaller. People using skinnier and skinnier core biopsies. So in our laboratory, we have trained our technician to be very careful. Practical tips. Let's say if you receive 4 core sample in a specimen jar and a skinny core, let's say core fragmented core, a few more than 2, let's say more than 2. And in the past, people just, when they do direct transfer, they put everything in the one block. So one block, and we do serial section. Like I said before, for lung, we do 18 serial section. And we stain 3, 1, 9, and 18 at 4 micron. And then the rest, we put it on spares for further tests. So in the past, in some inexperienced technician, and we can't blame them, they don't know. They put everything in one block, and when they face the block to get to the full face, they cut out. So, and then it's lost, gone. So we have changed our protocol. We said to the technician who does the direct transfer that if you have more than 2, you have to separate that in 2 blocks, because 2 blocks. So each block would have either 1 or 2 cores. So in that case, when you do serial section of 18 ribbon, you end up getting 36. Because each block you do 18 ribbons. So when you do immunostains, you only need to stain 1 block. The other block, we have totally all the material for you. So do not put everything together in 1 block. You will lose it. And secondly, we also express our concern to the clinician. I know it. They know that if they give us very little, the radiologists know, and we have good radiologists, and they know. So it's a collaborative effort to minimize repeat biopsy on the patient, because each time it's costly and it costs pneumothorax for the patient. So it's not the ideal thing. Now, sometimes when we're desperate, like they do cytology, say they do FNA for lymph node staging when they do core biopsy, and we have malignant cells and we don't get any in the cell block. So what we do, we use the cytology slides, we send that to the laboratory, molecular laboratory, and they could actually scrap that material for molecular testing. And we have done that. And they could only do, say, EGFR or MET14, only 2. But at least that is better than nothing for the patient. So we are very, very conservative. We don't go and run whole 10 immunostains and then gone. Unless your cytokeratine doesn't work, then of course you have to get it working to see that it is actually carcinoma. So diagnostic tissue is still the most important, but testing for other things is also important. So it's always the consideration, and we learn all the time. We change our method in the lab. If we think this doesn't work, the next time we do something else and they know it. We used to cut only 9 ribbons, but now we cut 18, because every time you put the block onto the microtome to cut, you lose tissue. When you face it, you know, the paraffin block, tissue is lost. We can't minimize, we collect everything. And I mean everything. Yeah, that was we get very mad, very mad. Yeah. Dịch hả? Có cần nói tiếng Việt không? Hiểu không? Hiểu không? Khi muốn nói là khi mà mình có rất là ít cái tế bào á, thì mình phải chia nó ra, mình đừng có để chung hết, mình đừng có để một cái block. Tại vì một cái block nếu khi mà mỗi lần mình cắt để vô cái máy cắt á, thì nó cắt hết cái tế bào ra, cho nên mình phải chia nó ra. Rằng mình làm một cái block, còn cái block kia mình save, so saving, you know, mình để dành save. Yeah. Okay. Next one. So breast. In our institution, we have breast screen. So I come from one of the hospitals where we have breast screen on site. So breast screen in Australia is to screen ladies, young ladies of maybe 50, I think 50. They get routine mammogram, and it's a horrible thing. Don't recommend it. But anyway, it's a government thing you have to do. So therefore, we receive regularly, almost every day, breast core biopsies. So talk a little bit about biopsy techniques, what we have available in our hospital. And I have chosen just 2 areas of breast to talk about because, again, nobody wants to see the typical breast, you know, ductal carcinoma, lobular, you know, all the time. You see that all the time, I'm sure you do. So just some interesting little things that I thought I'll just present, and just a couple of cases just to demonstrate little interesting things. So biopsy technique, a lot simpler in breast core. We have, so the reason for biopsy is for histological diagnosis, the radiology detect calcification. In Australia now, it's very rarely that the person present with a big breast lump because the detection is so early now. A lot of the time is impalpable breast lump, and it's usually calcification. And our breast lesion is so small, like under 10 millimeters, that's seen on radiology. So it's very advanced technique. So we have whole biopsy, percutaneous. They're cheap, they're simple, but it's very skinny. So they need multiple cores. And I will show you the pictures of what I mean. So we have the other one is vacuum assisted biopsy. So it's a vacuum suction. So this is, we get lots of tissue. It's almost like a big pieces of tissue, and it's very good. But those ones, they're expensive, a bit more expensive to do. And they may actually remove completely the lesion. So when you have a malignant lesion, say, and it's very small, and when they do re-excision, it might be gone. I mean, the radial scar might be gone, or the small ductal cancer might be gone. So anyway, both has advantages and disadvantages. And the big pieces of tissue is our responsibility to do lots of levels we have to do. So this is an example of what we get on the slides at our hospital. You can see here, you can see R represent ribbon and L represent level. So the core biopsy is so small. You can see how skinny compared to these fat, big pieces that you get in vacuum suction biopsy. So I normally do levels on these. Even if I see the calcification, I got routinely, we get given 9 serial section, because the lab uniformly just give us 9 serial section. So I know when I look at the macro, and I said, oh, it's 25 millimeters aggregates of tissue, which means it's a vacuum. You know for sure it's vacuum, because core biopsy, they will measure, say, a core of 10 millimeter core or whatever. So I know I need to do levels into it, and I routinely do 6 levels to get in. It's more tedious, but I will manage to detect anything small, because you can see how big, fat these things are. See, and I even dot a lesion that, you know, there for meeting purpose. They like it like that. Save them from, yeah. So I just want to have a brief word on columnar cell change of the breast, lesion of the breast, because this is what we get very common in breast core biopsies. So what are they? There are three areas of columnar cell change. maybe a bit boring, but anyway, these columnar cell change, columnar cell hyperplasia, and flat epithelial atypia. So the columnar cell change, if I'm sure you all have seen, is very common in breast core biopsies. These are dilated ducts. They classically lined by 1 or 2 cell layers, epithelial cells. The cells are ovoid and they're lined perpendicular to the basement membrane. And the classical features is apical snouts. So you get these cytoplasmic flaps or snouts, and they have, if you do ER, they will have higher expression of ER. So an example, so dilated ducts with containing proteinaceous material, sometimes the calcification, and then you can see the little snouts, the little heads on the top of the cells. If I can see, show there. And this is a classic example of columnar cell change. Yeah, yeah. So we get them all the time in breast core. So don't call them atypical ductal hyperplasia and make them take them out. And I've seen it happen. So, and then the columnar cell hyperplasia. They're similar to columnar cell change, except the cells are pseudo-stratified. So there's more of them lining the thing, but they don't have complex architecture. So they still dilated duct, just lined by more cells with the apical snout. Simple, and they have very low Ki67. Again, if you do estrogen receptor staining, they'll be upregulated, stain more. Now, so just to show you an example of what things look like. So this is on the right-hand side. This is columnar cell hyperplasia. You can see even at this power, the apical snouts. Sorry, I like to take low power view photo because my supervisor, my mentor, you know, like Esther said, she has Stan McCarthy, and he said he's a lower power pathologist. Anyone who go high power pathologist is actually a low level pathologist. So I still remember that. So my photo, I like low power. So it's a pattern recognition. So it's really important to recognize. So on the left-hand side here, you can see this duct. This duct contains lots of cells. When the duct in the breast contain lots of cells and all over the place, lots of them, and looks worrying, they're not. They're usual ductal hyperplasia. So the more disorganized they are, the benign they are. So on the right-hand side here, these are columnar cell hyperplasia, and I always look for the apical snouts. That is the classical features of them. Now, so sometimes you get combination of usual ductal hyperplasia, you can see here. So they all over the place. And then columnar cell hyperplasia. So benign cluster, because at lower power view, you can see they still have the lobular architecture. So they still organized in the lobular unit. So do not call them atypical, because if you call anything atypical, they remove it and you don't find anything. On this hand side, the usual ductal hyperplasia, you can see here, see that lots of cell lining filling up the lumen of the duct, and they're streaming at all over direction. They're very disorganized, they're everywhere, and the usual ductal hyperplasia. My recent attendance to the USCAP in where was it? Oh, Amsterdam this year. The lady breast pathology gave almost half the lecture on usual ductal hyperplasia. So there you go. It's actually an important recognition. But I don't think I can stand the whole half lecture on usual ductal hyperplasia. So anyway, so the next item, the moving on from columnar cell hyperplasia, is flat epithelial atypia. So they are, the difference is the cytology of the cells. So they have architecture similar to the columnar cell hyperplasia, but the cytology, they became, the cells are big, they prominent nucleoli, they still can have the apical snout because they are columnar cell in origin. But they can show stratification, but no micropapillary and no Roman bridges, no cribriform architecture, but the flat pattern is maintained. And again, the ER pattern is increased, increased staining. So why is it important to distinguish flat epithelial atypia? I mean, the management of them is quite controversial. In its own, the flat epithelial atypia is actually not much of an importance. But the important is they often are associated with or adjacent to other atypical lesions in the breast. for example, you know, ADH, low-grade DCIS, even malignancy. So in core biopsy, when you see them, you just report like flat epithelial atypia, and then they correlate with the radiology, and they said, okay, this is an atypical area, and we don't think we get it all out. The radiologist who does breast all the time, she knows that this biopsy is not representative, and we need to remove the area. So it is really important. I mean, the risk of progression of FEA to invasive cancer is low when it's isolated, and the management is controversial. Some hospitals don't do anything, but like I said, it depends on what it is associated with. So you need radiology for pathological correlation. That's why we have breast screen meeting. You know, we present atypical cases to them, and then they look at the radiology, and together they derive at a management plan for the patient. And this is a short lecture, so I'm sure you can fall asleep after this. So, so FEA, here it is. The cells are flat. You can see mitosis here, and it's just atypical, but they're still flat. And then just on comparison next door, you can see this duct here has start having this cribriform architecture, but it's still irregular cribriform. They're not rigid. So we just call them ADH, and the FEA is next door. I think it's still very subjective. Some pathologists have very low threshold of calling FEA. Some have higher threshold. So it varies. This picture demonstrates, you can see on the right-hand side here, this duct here have all these irregular cribriform architecture with micropapillae here, and the FEA, the difference. So when you have ADH, they remove it. The surgeon is always in a meeting at our breast screen meeting every fortnight, and they remove all these ADH lesions. So immunostains, you can all read the ER/PR positive, Ki67 slightly raised, the luminous cells negative for CK56, and positive for the usual. Yeah, so we don't often do this, just for completeness, I mentioned. So the differential diagnosis is all these, you know, you have to differentiate them from ADH, and DCIS are the main thing, and apocrine lesion. I mean, don't underestimate UDA, usual ductal hyperplasia, because sometimes it's quite difficult. It is difficult. And my approach to this is look at it low power. When you look at low power and you see something, a lot of cells, but they're so all over the place. They're not non-polarized. They go, one cell go this direction, another cell go that direction, and they fill up the duct. It's UDH. So, you know, it's not the DCS doesn't do like that. So always low power. So let's move on to the next topic, second last topic, papillary lesion. So for completeness, I gave a list of what we get. So we get benign papillary lesion. We get a lot of these, actually, intraductal papilloma and atypical papillary lesion and malignant. So with the malignant lesion, I just want to, I will give you some example of the non-invasive, the papillary DCIS, the encapsulated papillary carcinoma, and the solid papillary carcinoma, and tell you the difference. Now, the invasive, the one of importance is actually the invasive papillary carcinoma is quite rare. And it just means like the usual ductal, it's just the cells are more in papillary architecture. But the micropapillary carcinoma has a distinctive appearance, and you just need to recognize them. We did put one in our exam in the past, didn't we? So intraductal papilloma. Now on core biopsy, it's important to recognize these intraductal papilloma, because if it's a small lesion, they don't do anything. If it's 4 or 5 millimeter large lesion, they might excise it. So what are the features? So basically you have papillary lesion, and you have, and they are those are what we call bimodal, because they have epithelial and myepithelial cells, like we had in the cytology case. So let's show you a case to demonstrate this. I have a 70-year-old lady who has a 6mm lesion in the left breast, superior to the nipple. These lesions are often central. You can get periphery, but often they're central and they very closely associate with the nipple area. So that is a bell. You know, when the surgeon remove doing a microductectomy, the nipple, they always looking for papillary lesion. So she has a percutaneous core biopsy. And there it is. This is the case that I have a few weeks ago, my classic with papillae. Can you see, can everyone appreciate these papillae? And they have like a little capsule that I managed to capture on my low power view. Not very clear, but anyway, these are those papillae. So what do papillae mean? Do you know? Papillae means the finger-like projection. So the finger, they have a fibrous a core, and then it's come out. So I used to tell my medical student papillae, like finger-like projection. So in the skin, you call verrucas, like finger coming out. So these are the same. Can you imagine these are the fingers? I mean, I don't have reindeers or whatever like that. My imagination is not very good, but anyway, the finger projection. So on high power view, they are lined by, believe me, they're lined by 2 cell layers. So the epithelial cell on the top and my epithelial cell is at the bottom. And then they have sometimes, you know, you get these little tufts of papillae that break off and just floating around. So a good sign is when they have apocrine metaplasia within the papillary lesion. So these are the one, these pink cells, they're apocrine metaplasia. So when you do the myoepithelial cell staining, they're positive for P63. You can see those myoepithelial cells, and they both positive in the papillae and in the capsule surrounding the lesion. So it's going to be positive in 2 areas. There, so you can see the P63 at the capsule of the lesion. And the cytokeration 5/6 is the same, but it's not as clean. I mean, CK56 is not as clean, but there it is, so intraductal papilloma. This case was shown in the MDT, and we just tell them it's an intraductal papilloma, but because on radiology, the radiologist was concerned it's a little big. It's 5-6 millimeters or maybe a little bit bigger, so they will go and excise it. But she won't get sentinel node. So that's the difference. If you say something atypical only and they excise, the lady doesn't get sentinel node biopsy. So, but if you call DCIS or invasive cancer, they operate on the patient and at the same time, sentinel node biopsy will be done. So atypical papillary lesion. Now, this is a little bit more difficult because you have papilloma, and then next to the papilloma, you have atypical ductal hyperplasia or DCIS. So let's demonstrate with a case. So here it is. So on the right-hand side, this is papilloma, the typical papilloma, and look at this area next to it. That is the atypical area. And the atypical area here, you can see it's almost like it's atypical ductal hyperplasia where irregular cribriform architecture, a lot of cells proliferate. So we call it atypical papilloma. Now, papillary ductal carcinoma in situ, I just mentioned very briefly. Essentially, they are variant of DCIS. So they have negative no myoepithelial cells in the papillae, but in the surrounding tissue, the capsule they have. Pure papillary ductal carcinoma in situ, you see them in a part of DCIS in other areas. So they're common, but you don't really think about it calling them single, you know, you just call them as a spectrum of DCIS. So here's a picture on the core biopsy. Remember, these are all I have is core biopsy. And there it is. That's what it looked like. Now, come to this, my favorite lesion, because just the last few weeks, I keep getting 3 or 4 of these. So I thought, oh, this is really good to take some photos and show you what they look like. So they are solid. The other terminology in the past people use is encysted papillary carcinoma. And I show you why. in the past. That's what they call it. So they're solitary, they have a capsule, they're papillary lesion, but they also have cribriform architecture, and they are surrounded by a thick capsule. They have high risk of local recurrence, and the way we treat them is we treat them as carcinoma, ductal carcinoma in situ. It's in situ carcinoma. And I think they, from memory, they don't get sentinel node biopsy when they excise. It has to be excised. If you call these on call biopsy, they're gone, they're excised. So I have on call biopsy, I have this lady with, I think this is from my colleague, because I have the re-excision, and my colleague at DHM get the call biopsy. So because I work in two places, I managed to borrow, and here it is. So on the core biopsy, you can see the capsule, thickened capsule in the papillary projection. And on higher power view, so papillae and cribriform area. You can tell is from our DHM slide because of the pink, the blue ink, because we don't ink our core biopsy on the edge. So we have P63 completely negative, CK56 completely negative. So we call this encapsulated papillary carcinoma. So she went ahead and have an excision. So this is what we have at St.George Hospital sample. So our registrar, we receive a lumpectomy, and our registrar orientated and painted and cut slides from medial to lateral. So medial to lateral. And this is a classic appearance of encapsulated papillary carcinoma. So when they call me out and have a look, which section to take, I looked at it and I said, this is encapsulated papillary carcinoma. Because when you look, you can see that it's cystic. And that's why the old terminology is called encysted papillary carcinoma, because they're partly cystic. And the cyst, you can see the cyst here, and then in solid areas right there. So where do you take section for examination? So I'll tell my registrar, take mainly the solid areas, because we're looking for invasion in these. So I managed to screen a low power view of the thing, and you can see the capsule right there and the solid area projecting into the lumen. So the higher power view of the area shows cribriform, and you can see very nicely a little papillae here with the fibrovascular core, and that's the cribriform area and the capsule. So no invasion. So this is good. No invasion. We sign it out as encapsulated papillary carcinoma, no invasion. We repeat the immunostains and P63 and CK56 all positive. So if the myoepithelial layers are positive, negative, no staining, how do you assess invasion if you have invasion? So what do? You can't use immunostain because they're all negative. When invasion, they're also negative. So what do we do? Oh, we'll show you later. So this is going to the next one. This is solid papillary carcinoma, and this is a lesion that is expressed neuroendocrine differentiation. So they're solid. They have also negative myoepithelial cells in the papillae, and the myoepithelial cells are present in the periphery of the lesion, but it may be absent, but usually they're present. So they have low Ki67 staining, and when they invade, they often become mucinous carcinoma, and then they still show neuroendocrine differentiation. So here it is. I managed to find a case. It's not common. It's not common. It's encapsulated papillary carcinoma. Very difficult to find one, but I dig through my old cases, my record, and I found one of mine. Here it is. So that solid areas, you can see the cells are very uniform. Remember, when you see uniform cells with a bit of granular cytoplasm, think of neuroendocrine. And the cytoplasm, the stroma often hyalinized like this. So very hyalinized stroma. And there it is, the P63 negative in the center and positive in the periphery. All good. And then, but next door, when we look at next door. So here it is, up the top, this is solid papillary carcinoma, and here is invasion. So again, the same question, how do you assess invasion? I mean, in this solid papillary carcinoma, because it's easier because the periphery got P63 staining, and this invasion, it will be negative myepithelial staining. The mucinous, it often expresses mucinous. So when you have a mucinous carcinoma in breast, you look. Maybe you can find some ductal carcinoma in situ that is solid papillary carcinoma because they often are associated with them. And they often occur in elderly people, elderly ladies. So here it is, synaptophysin staining very strongly positive and ER very strongly positive. So invasive micropapillary carcinoma. So this is a classic pictures that is really a good example. So when you look at it, you remember what it looks like. When you see it again, you won't forget. So basically, the lesion of clusters of cells surrounded a cleft-like space clearing, and they don't have, even though they say micropapillary, but they don't have fibrovascular core. They just clusters of cells or morals of cells with cleft-like space. And when you do certain stain like EMA here, is a picture that's classic pictures, cleft-like space, clustering of cells, and they look almost like they're in the lymphatics. They do have a high risk of lymphatic invasion, but in this one, they are not. They're actually just sitting in cleft-like space. And the EMA is very strong, staining at the periphery. So they're inside-out arrangement. Because usually when you do EMA in a normal ductal carcinoma, they'll be inside. They'll be the basement membrane kind of area. But this one is on the outside. These invasive papillary carcinoma, I won't say because it just looks like the ordinary ductal, but it just has papillary configuration. Now, so what do we do when we have papillary lesion on core biopsy? If you call intraductal papilloma and it's small, incidental, like a couple millimeters, they won't do anything. But if it's 4, 5, 6 millimeters, and they think clinically it's a bit big, and even though we don't get it all in the core biopsy, they will go ahead and excise it. I didn't, I don't know, some of my slides were missing, but what I meant to say, I have some slides that show you what you get when encapsulated papillary carcinoma become invasive. And you cannot rely on your immunohistochemistry stain for my epithelial cells. So you have to rely on your H&E. So the H&E appearance is infiltration of the fat. So if you see the capsule and you see the cell go beyond the capsule into the fat, that is invasive and cancer arising in encapsulated papillary carcinoma. So just a little bit about calcification on breast core. So usually breast core in our institution, and I'm sure other places, are done for calcification because calcification is often associated with ductal carcinoma in situ. So we get a core biopsy, we get vacuum-assisted biopsy, and the calcification are calcium phosphate and calcium oxalate. So what happens when you have a core biopsy and you don't see calcification? So what do? You do levels. You do levels and you still can't see the calcification. So you take the block and you send it to radiology. And the radiology x-ray that block and said, calcification is there, but we said we don't see it on our core biopsy. So what happened there? So now we have the calcification in DCIS straight there. There's high-grade DCIS, straight calcification, oxalate, so calcification phosphate right in the middle. Calcification in benign ducts, calcification in columnar cell lesion here. So we have this core biopsy. They said they're looking for calcification. They don't see it. So what do we do? Now, I've asked this to my colleague, I've asked to my registrar, and a lot of them don't know. But we have, it's calcium oxalate. So calcium oxalate, how do you detect calcium oxalate? So with the microscope, you polarize it. So look, polarization. There it is, calcium oxalate. So you are in the lesion. And I'm not sure if the textbook have it, but anyway, there you go. My senior colleague taught me, and now I'm passing on the information. So, you know, otherwise, if you don't find it, you tell the radiologist who did the biopsy and said, no, it's not representative. And you can do levels to the cows come home. I mean, you can do cut through your blood. If you can't recognize it being calcium oxalate, you won't see it. And believe me, my exam viva, there was a question, what do you do with calcification in breast lump when you can't find? What do you do? And yeah, I remember to this day. Okay, my case. Nearly there away. So I have a 50-year-old lady with some indeterminate calcification at 7 o'clock left breast. Breast screen detected on routine screening, as you know. 50 years old in Australia, we get routine mammogram. And so they did a vacuum because you can see 25 millimeter biopsy. It's really big. And it mainly consists of fat. So I managed to find, so this area calcified. You can see that calcification here. And then throughout the thing, almost miss it, but little strips of epithelium right there. This time we have to go with high power because I can't, you know, this time we see, oh, some strips. So on high power, we saw these clusters. It's my colleague's case, and we looked and we said, oh, this is very abnormal. Just very tiny, small amount, but we insisted that this lady have a biopsy, I mean, a excision, because it's calcification detected, atypical epithelium. So I have the excision. So here's the excision. This is high-grade DCIS. And what it is, you can see here, there's a calcification dropout, and then little this thing. You see the little knobbly micropapillae that are floating around? This is what we found in the core biopsy. So a long story short, don't ignore anything, little epithelium. And when there is calcification that they say is abnormal, pay attention and take notice. Another case, just the last one, the apocrine lesion, 52-year-old with 10 millimeter mass in the right breast, and they suspect it's a lymph node or invasive cancer. It was difficult biopsy. I don't know why it was difficult, but they gave us pretty good core. Here's the core, and you can see there's a lot of dilated duct with apocrine cells. And, you know, apocrine cells is really difficult on core biopsies. Sometimes they can be a bit atypical, but do not call it ductal carcinoma in situ, because apocrine cells can have prominent nucleoli. They can look horrible, but your threshold calling DCIS with apocrine lesion have to be high before you call anything DCIS. So we call it apocrine papillary proliferation, could be papillary apocrine hyperplasia, and then benign. But what can you do? I mean, my epithelial cells are absent, so you have to depend. It's not common, but it does happen. And the ER negative and the estrogen receptor positive. So it's just an interesting case, and I thought I'd raise that. And so next time you see an apocrine lesion, just be careful. Just don't, when it's atypical, don't just jump in and say, this is DCIS, because I have seen it. Yeah, very last case, my most recent case. So a 72-year-old lady with a right breast mass, and she has a axillary lymph node. So they said, oh, it's metastatic breast cancer, and let's just biopsy both. So the core biopsy of breast, very good core with lots of inflammatory background. There's pale areas here. This is large, malignant, very malignant, and very inflamed in the background. So what about the lymph node, the axillary lymph node? They are very sure is metastatic. So the core biopsy of lymph node, and she has no history, anything else, no lymphoproliferative, anything. So basically, it's a two core biopsy, shows a diffuse infiltrate of mainly small lymphocytes. So it's abnormal. You can see it abnormal with abnormal architecture. And so we did all these stains, and it's CD5 positive, 23 positive, 20 positive. She's got CLL. So we make the diagnosis of CLL, and she has no history of CLL before. So the take-home message is not all axillary lymphadenopathy in a lady with breast lesion is metastatic, and sometimes metastatic lesion can occur on a background of lymphoproliferative. So you just have to assess, and but a negative lymph node core doesn't mean that she doesn't have metastatic disease. It just means the core maybe haven't gone through the area. So you just have to report as is, and anyway. Oh, and summary. The core biopsy of breast is often small, so you need to do ribbon rather than levels, because otherwise you lost it. And the vacuum suction are bigger piece, so you can do levels to detect lesion and correlate with. And my epithelial marker is very important. And I didn't show any radial scar, but I'm sure you all know radial scar. My epithelial markers is important. And yeah. Oh, and this is another picture of the flowers in my backyard. This is camellia, a red camellia that looks like a rose, but it's not a rose. Rose is very difficult to take care of because they have thorn and you have to prune them at certain time. So I can't do it. I'm really bad. So I do camellia. And camellia where I live is plentiful, and they like the clay soil. So yeah, there you go. So every year when they first flower come, I go and take a picture. That's the end.
Thank you for your wonderful presentation. So just like your previous slides, I would love to give a summarize for your presentation in Vietnamese. Thì đối với bài báo cáo của bác sĩ Kim Trần, chúng ta sẽ có một số những cái điểm lưu ý chính như sau. Thì đầu tiên thì đối với các tổn thương mà dạng tế bào chủ ở vú, thì chúng ta sẽ có 3 nhóm tổn thương chính, trong đó là các thay đổi tế bào hình trụ, các tổn thương tăng sinh tế bào hình trụ và các bất thường biểu mô dạng phẳng. Thì trong đó các thay đổi liên quan tới tế bào hình trụ được đặc trưng bởi sự giãn nở của các tế bào của các ống tiểu thùy đi kèm với các tế bào có dạng thay đổi điển tiết. Đối với các trường hợp mà tăng sinh thì cần lưu ý việc các tổn thương phát triển đa hướng tạo ra các tổn thương này có xu hướng phát triển đa hướng, tạo ra một cấu trúc chiếm trọn lòng ống, thì tổn thương càng phát triển đa hướng, càng chiếm trọn lòng ống thì có xu hướng càng lành tính. Đối với các trường hợp của tổn thương bất thường dạng phẳng thì cần lưu ý vì các tổn thương này thường đi kèm với các tổn thương bất thường khác như là ADH hoặc DTS, do đó cần phải lưu ý khi mà phát hiện tổn thương cần đánh giá các tổn thương đi kèm theo. Đối với các trường hợp tổn thương dạng nhú ở vú, chúng ta có các tổn thương như cần phải lưu ý, trong đó có carcinoma dạng nhú có vỏ bao. Đây là một tổn thương có tỷ lệ tái phát cao, tuy nhiên không đi kèm với các dấu hiệu của đặc điểm của xâm lấn, vì tổn thương này về đặc trưng có vỏ bao thể xơ. Các trường hợp của carcinoma nhú đặc thì cần phải đánh giá các trường hợp nếu như có carcinoma nhầy đi kèm, và đây là thành phần xâm nhập. Do đó nếu như thấy hiện diện đơn thuần là carcinoma nhầy xâm nhập thì chúng ta cần phải đi tìm thêm các thành phần của carcinoma nhú đặc ở trong ống khác. Đối với các trường hợp của ung thư biểu mô vi nhú xâm nhập thì đây là các trường hợp khi đánh giá trên hình ảnh giải phẫu bệnh đôi khi có các artifact làm cho hiện diện các khoảng trống mô. Do đó cần phải tránh nhầm lẫn với các trường hợp của xâm nhập mạch, mặc dù cái nhóm tổn thương này có xu hướng xâm nhập mạch rất cao. Các trường hợp mà vôi hóa ở trong sinh thiết cần có sự tương hợp với kết quả trên hình ảnh học. Do đó nên cần cắt thêm nhiều lát và cần có tương hợp. Đối với các trường hợp của canxi oxalat đôi khi cần phải dùng đến kính phân cực. Và một lưu ý cuối cùng quan trọng là không phải bất cứ tổn thương hạch nách nào đi kèm với carcinoma tuyến vú cũng là carcinoma di căn. Cần phải đánh giá cẩn thận, và đặc biệt trên các trường hợp có tăng sinh mô lympho có thể làm ẩn giấu hoặc là che giấu các trường hợp mà carcinoma di căn tới hạch. Xin cảm ơn các bạn.
So thank you so much for a very nice case and nice very nightmare biopsy. I would ask you one question because some slide you show some typical hyperplasia on the core biopsy. and at the periphery of the lesion, there are some single gland, but very near to the main lesion. So in that case, how we can differentiate a micro invasion with a single gland versus the tangential section. So with a small biopsy.
Small biopsy, like when you have, say, something ADH or A, usually you don't get invasion in ADH, right, from ADH. So you've got to make a diagnosis of DCIS, and then you look for invasion. But then sometimes a few cells drop out. So you have to be careful and look at it, the whole lesion. If any problem, you always do serial section, like serial next to it. And then if you're not sure and you think you worry about it, you can always express that you are suspicious of few cells and you cannot exclude invasion. So that terminology, I mean, I always tell my young colleague, if you are not sure and you worry about it, you show to your colleagues and nobody is sure, then it's okay to say, I can't exclude an early invasion. And then the clinician will look at radiology, look at various things. And worst to worst, they just do a sentinel lymph node. Because if a DCIS, they have to remove anyway. And often DCIS, sometimes they do sentinel lymph node. And we have cases where sentinel lymph node is positive, but the main lesion, we can't see the invasion. And I'm sure you have come across that too. And you can't find it. So what to do with that case? We can only say, well, the staging have to go on the metastatic lesion from the, axilla. So don't be afraid of saying, I don't know, I'm suspicious, but you've got to further investigate, give me, exercise or do something. So at the end of the day, it's the patient, the other side is the patient. And I'm sure if that lady has DCIS, she wanted out, yeah.
So is there any ancillary test like a myoepithelial marker?
If you have 1 or 2 cells, it's very difficult to do myoepithelial to assess unless you have a lot. Yeah, you can't rely everything on myoepithelial because myoepithelial cells is not a continuous stain. So it's patchy. So some area you do, it might be negative, but it doesn't mean it's invasion. It's very difficult. And one of the most difficult area I find is still papillary lesion of the breast. Yeah. And even the whole thing is excised, we still can't decide which is invasion and which is not because the myoepithelial cell does not help.
Bị nói sơ với mấy bạn đây, tại câu hỏi mình hỏi là trong mấy cái tăng sản không điển hình đó, mà nó cái tổn thương chính cái bên nó đôi lúc nó có những cái tuyến nhỏ xung quanh, một vài tuyến, thì lúc đó là nó là một cái dạng vi xâm lấn hay là một cái dạng mình cắt mà mình cắt mặt phẳng trước tuyến á, thì nó gây ra chuyện đó. Thì là đặc biệt là đối với mấy tuyến nội tiết, ví dụ như là tuyến vú, tiền liệt tuyến là mình cũng gặp cái việc đó. Thì cô nói rằng là đúng là cái việc đó là khó, nhưng mà mình thứ nhất là mình phải cắt nhiều lát để mình khảo sát coi nó thiệt là trên nhiều lát mình thấy hay không. Thứ hai nữa là đừng ngại là khi mà mình phải mời mọi người cùng coi, cái đó rất là quan trọng. Và thứ ba nữa, nếu mà mình không có kết luận được thì mình chỉ ghi nhận là mình nghĩ cái đó là nó có cái chỗ đó mình chưa gọi tên được là cái gì. Còn mình hỏi rằng là có dùng mà một số marker để có thể giúp hay không thì cũng nói là rất là khó. Thì đó là cái chia sẻ với lớp như thế.
It's very important in your pathology report. If you come across a difficult lesion of any difficulty, if you said in your report that you have shown to certain colleagues, so you presented as a collective report, it has more noise. Then you just say, this is my decision. But if you put down at the end, this case was difficult and I have consulted my colleagues and the colleagues is very, very happy for you to name them, or, you know, whatever, or intra-departmental opinion have been obtained. So that is a collective approach. And I think that is a really important thing, because some clinician would say, very rude, some rude clinician would say, have you shown to this? Have you shown to that person? And why not, if you have it and you said, I have already shown, and even if you send that case away, and another consultant pathologist from St.Geogre would look at it and said, oh, they have shown to various people. So they take notice of that, and they know it's difficult, you know? So that is really a practical point that I like to say. Don't hesitate showing to others. That's how you learn. Yeah.
So we would like to give your we would like to thank you for your great presentation today. So before we move into the next part of this afternoon conference, I would love to invite you guys to have a rest, and we also prepare a little tea break for you guys out there. So we will come back in about like 15 minutes. Is it okay?
The next part of the talk is like as I said, you guys will do the talking, and I am tougher. So I am not talking, I'm giving the section, and I'm going through every single one of you, one by one, just like I do with my medical student. So basically everyone got to give me what they think, because I'm sure you have seen this. So don't run away. I remember who's at the end.
Xin cảm ơn tất cả mọi người. Thì ban tổ chức có chuẩn bị sẵn một số phần tea break, thì mọi người có thể nghỉ ngơi trong vòng 15 phút. Sau đó chúng ta sẽ tiến hành quay trở lại tiếp tục với chương trình. Ngoài ra thì một số câu hỏi có gửi tới các giáo sư và bác sĩ ngày hôm nay, thì xin phép là ban tổ chức sẽ chỉ lựa chọn một số câu hỏi thôi. Ngoài ra thì những câu hỏi còn lại nếu như chưa trả lời được thì xin phép sẽ gửi mail trả lời trực tiếp tới các bạn các câu hỏi sau. Xin được cảm ơn ạ. Xin được cảm ơn tất cả mọi người đã chờ đợi. Thì bây giờ chúng ta sẽ quay trở lại với lại cái phần tiếp theo trong cái bài báo cáo, cũng như là phần thực hành với lại các slide ảo trực tiếp với bác sĩ Kim Trần.
I think I talked too much, so the microphone is already exhausted as well. So, okay. I'm presenting, this is part of yardstick, small biopsy and spectral techniques. This is part of our part 2 examination for the Royal College of Pathologists of Australasia. So I'm presenting on behalf of Dr. Kate Merrick from DHM. She has prepared these cases. So any problem, refer to her. I'm just a delivery. So we have, I can monitor myself. All right. So everyone has seen these cases. Yes? Yes, yes. So, yes. So case 1, 80-year-old female chest wall biopsy. So if I show this, can I have the young gentleman from the back describe please and tell me what you think? Yeah. You. Oh. Yeah, anh đó. Oh, technology guy, you, not you. Also this you. The young gentleman over here. Yeah. It was like that. It's Kate's thing. It's not me. But they have seen it. They have seen low power. You tell me what you want, and I will. So present. Yeah. Section show quickly. You're doing small biopsy exam. Make mistake. Describe. Yeah, describe. Nói tiếng Việt cũng được, nói tiếng Việt. Yeah.
Em nghĩ là carcinoma tuyến. Anh đi đâu?
Carcinoma. Malignant. So tả đi. Đừng. Tả đi.
Dạ, tại thấy có cái khối một đám tế bào.
Mình trước first thing phải describe what tissue is it from. What tissue is it from? So what tissue?
Ở đây em thấy là da, bởi vì
đúng rồi, da.
Ở trên nó có cái lớp lớp thượng bì, năm lớp, sáng nay có mô tả.
So he said that is a skin biopsy because we can see the epithelial.
Esther, it's because you don't understand Vietnamese. And he said, yeah, it's correct. I want to give him 10 points for this saying this. Okay. So, what's in the, cái gì trong cái da? What's inside the skin? What are these? Cells, just describe. So all you need to do, I tell you a secret, all you need to do is describe cells, malignant or benign cells. What kind of cell? Your friend would. Yeah. Oh, he will help. Yeah.
I think it's the last cell with molding kit. The nucleus is typical. It's can see commitment nucleoli, and you can see mitosis.
My head was the hand. Yeah, the hand is so good. This arrow is good. Look, I can tell you. But yeah, look at this. This is an advanced compared to the last. Yeah, go on.
It's kind of look granular architect.
So let me help you. So what are those those things? Mình hiểu.
Em thấy kiểu như giống như cái tuyến carcinoma tuyến. Cấu trúc tuyến.
Nhưng mà mấy cái lỗ này lỗ gì vậy ha? Lỗ gì? Mấy cái lỗ này cái trong cái người có cái lỗ nào có máu ở trong?
Dạ.
Yes. So that tumor malignant tumor that form blood vessels. What are they? So cái nào mà
sarcoma.
What's the name for blood?
I think angiosarcoma.
Yes, no, 10 point for the teacher. All right. So whenever you sleep like states like that, think of vessel, yeah? When you
Yeah, yeah.
Then so angiosarcoma. This is a lady. So lady, they when they have breast cancer, they get radiotherapy. So many years after radiation, they get this effect of radiation is angiosarcoma. So she has this is a mastectomy specimen. That yeah. So read all about it. Sarcoma. They're very, very horrible. It's a radiotherapy. Clinic. Positive. Herb. But come on, you know. So that's all you need for the exam. Phase 2. Next estimate. 72-year-old male with right pubic symphysis, head avid, very metastatic. You've seen this? Diễn tả. Describe. Nói tiếng Việt thì nói tiếng Việt.
Cái slide hình ảnh. Yeah. Yes. Dạ, cái này thì em thấy một cái mẫu sinh thiết xương. Dạ. Với những cái bè xương. Còn lại là những cái cấu trúc nó hơi bất thường ở trong đó. Malignant. Benign.
Newborn form. They like my voice through the microphone. Yeah, so osteoclast eating away the bone, or osteoclast forming the bone. Okay, so what do you think the process is? If Kim nói benign. Anyone know what the in is?
Make someone happy.
Make someone, yeah.
Can you?
So it's Paget's disease of bone. So this is quite a good example. Paget's disease, benign. Anyway, in the exam, if you call malignant, is a fair. Yeah. So if you call reactive, maybe borderline. Esther, yeah. And if you call Paget's 100%, pass. Yeah.
Well, you need to know, thank you. You need to know what your normal bone looks like before you can call it abnormal, right? Now, normal bone has lamellae through it. It's got nice curvilinear lines that run in different directions. And if you polarize it, you will see it much better. But this bone looks like it's crumbling like biscuits. See the lines, they're abnormal. Am I right?
Yes. So if you polarize this bone, all you can see, normally when normal bone, when you polarize, you see parallel line. Nó dọc mấy cái dòng nó đi, nó rất là organized, nó rất là đẹp. Nhưng mà khi mà mình polarize những cái bone này á, nó all over the place. And that's not normal in the bone of this site. And when you see a bone that has a lot of high bone turnover, which means osteoclast eating up the bone, and the osteoclast keep making the bone. And unfortunately, on the digital slides, it's very difficult we can't polarize unless we take a photo of polarization. So this is a classic picture of Paget. But in the exam, you always say, please correlate with radiology, because radiology has a distinctive appearance, Paget's.
Thì cái phần này mọi người hiểu được không ạ?
Hiểu chưa?
Nắm được đúng không ạ? Thì xương của mình bình thường á, xương thì được chia thành hai nhóm chính là nhóm lamellar với lại nhóm guven. Thì lamellar sẽ là xương trưởng thành của mình, còn guven sẽ là xương mới được tạo ra, nó sẽ không có những cái xương đó, cái đường vân của nó sẽ không đi theo trật tự. Còn xương lamellar là do quá trình sau khi được tái tạo bởi các cái con tế bào hủy xương, con đại bào hủy xương, những con đó nó sẽ tái tạo lại cái lớp xương đó, cho nên nó sẽ có những cái đường đi rất là trật tự với nhau. Thì như chúng ta có thể thấy ở trên cái hình ảnh học này, thì cái xương này nó sẽ có cái đường vân này, nó không đi theo một cái trật tự nào hết. Tức là cái chất lượng xương ở đây nó sẽ có vấn đề giống như xương guven, tức nó không có giống như xương lamellar nữa. Đó. Thứ hai là hiện diện rất nhiều những con đại bào hủy cốt bào ở trong trường hợp này. Thì đối với trường hợp bệnh lý của Paget là một bệnh lý mà việc tái tạo xương nó xảy ra quá nhanh, nó cứ tái tạo đi tái tạo lại, dẫn tới cái chất lượng xương ở trong trường hợp này nó không có tốt. Do đó vậy, với lại là đó, chương trình cũng nói là chúng ta nên có một cái correlate, với lại tức là chúng ta nên có kết hợp với lại hiện học thì nó mới ra đưa cái chẩn đoán chính xác.
I think it looks very thickened. Okay, it's very thickened. Okay, next case now. Been working hard, so with the next to the the flower lady. Next one. Yeah, have you seen the slides? You have? Okay. Oh, you know, when I was training and preparing for exam, we have this session we call too hard. I mean, the difficult session. I'm sure Esther and Anita and everyone remember. So all the registrar come together every Wednesday afternoon, and we have a few hours. People bring difficult slides of interest from their different hospitals. It is in Sydney. So we spread all the slides out. Each table will get 5 slides. So everyone will go through and look at the slides. And then the consultant, one of the pathologist consultant will come and said, point, you describe the slides and tell us what it is. You describe, and everybody will make a record of who wrote, who said what. And so I remember Alistair, pathologist, one of the senior pathologists, I was still registrar in training, and he would come and he said, now, Kim Tran, tell me this slide, what it is. And I would say, sorry, I haven't seen the slide. Because I said, I come late, I haven't seen. And then he said, you don't have to, you do it now, describe now, right now. So I didn't get away. And then 10 minutes later, he would say again, Kim Tran. And I said, hang on, you just asked me that 5 minutes ago. So that's how I remember, with the torturing. But as we become more senior, we know the way out of it. We always, we discuss among our colleagues. And the other thing is bring your own difficult cases. So when you bring it, it's your case. And then when he asked Kim Tran, and I said, oh, it's my case. I know what it is. So I don't have to say it. Oh, young lady, please. I haven't forgotten you. 72-year-old female, left parietal convexity lesion.
I think this slide is full of neoplasm cell.
Do you know why the slide is kind of a bit funny? Do you think it's a normal H&E section? So when you see something that's not quite right, a bit fuzzy, a bit horrible, poorly fixed issue, you need to remember this is actually frozen section. Yeah, so that's why you don't get a good H&E material. In fact, the history should have said frozen section. So what do you say? Full of cells. What kind of cells? Epithelioid, spindle?
It's a spindle with
correct.
Vesicle.
Very good. Okay, your neighbor next door would tell us what she thinks it is. So spindle cell lesion in the brain, parietal, if I say dura, attached to the dura. Nếu mà Kim nói là nó dính ở trong cái màng não. Next, your friend will help you out.
I see a mitotic, a normal, a mitotic, and this is a wavy cell.
Wavy cells, I'm not sure about mitosis because sometimes they're a bit hyperchromatic, but frozen section a bit difficult. They look a bit busy, but I'm not sure if it's mitotic figures. So no necrosis. So what tumor do you know that attached to the dura, dính cho màng não, spindle cells?
I think melanoma.
Very good. Meningioma. That's what she said. Tiếng Việt nói sao? U màng não. U màng não, guys. Meningioma. Very good. 10 points. Okay. Meningioma. So if this lesion, this spindle cell lesion, if it's not in the parietal area, maybe it's in the cerebropontine angle, what differential diagnosis would you consider? Schwannoma. Schwannoma can look like that. Okay, so of course in brain smears, you do the brain frozen, do the smears. It means it's very helpful. So when you get the spindle cell lesion, you say the DD is either, because it's transitional, so you don't see the whorl that you normally typically see in the epithelioid type meningioma. So you ask the surgeon, when you ring up and you said, is it durally based? And he will have to tell you that it is or it isn't. So it is the meningioma. And assess other grade is for paraffin. It's not the purpose of frozen, for the frozen session assessment is not. So very good, 10 points. Next one. So meningioma. Different type. We won't bother going through. We just want to do diagnostic thing here. You can read all about it. Next one. This is interesting one, not so hard. Next lady. So 14-year-old male. Oh. Chronic right iliac fossa pain, lymphadenopathy. So what are we looking at? Cái này là cái organ gì?
Đây là hạch.
Hạch.
Đây là ruột thừa, tại vì có mô ruột với lại mô bạch huyết.
Very good. She said appendix. Ruột thừa, I understand. So what do you see in the appendix? You're correct. Thấy cái gì trong ruột thừa này?
Dạ là em thấy cái thành phần biểu mô ruột. Ý là thấy ở cái trong lòng của ruột thừa có cái chất, rồi có biểu mô của ruột thừa là biểu mô tuyến.
Cái này là cái gì?
Giống như là một cái sinh trùng đó.
Oh, very good. Oh, look at that.
Parasite.
Parasite. Do you know the name? Very good. I think she's 10 point already.
Con gì ta?
Con gì? Con gì? Cái worm này nó gọi là gì? Cái worm, cái worm này á. Oh, pinworm, tiếng Việt nói sao? Hả? Dung kim. Dung kim. I'm learning here. Dung kim. Pinworm. You know what? I tell you this funny story. When I was working in resident, like in the accident emergency, and so you have young children come in and they're crying, and you ask why they're crying. They're itchy. They're itchy down there, and you know why they're itchy? Because these things crawl out and hatch outside in the anus, so they're itchy. So what people do? They shine the little torch, and down the bottom. Is that right, Esther? And you can see the little thing. So these are the worms, and these worms have the hook. See the hook left? So do they cause appendicitis? Do you know? Not necessarily. They don't have to. Sometimes they can sit in the lumen like that. You just have to deworm the kids so they don't come back itchy bum. Yeah, the eggs. Yeah. Oh, the eggs are inside. The worm is actually in. They're very small. The eggs actually inside the worm. Then I look at the egg. So yeah. Yeah.
Oh my God.
Ông nói là ví dụ để cái thép á, cái thép là nói sao? Băng dính á, để cái bông the kid and then the worm will stick on to the. So the reason why the worm have to crawl out because it's cooler outside in the hatch. Then they crawl back in. So when they crawl, nó bò ra ngoài, nước tên nó là nước. So pinworm. So we call Enterobius vermicularis. Okay, next one. Are we back to this row? Who want to answer the next one? 90-year-old male, left nipple lesion. Show you some pictures, might help. So this is a nipple area. So what do you see? Who want to answer? Come on, don't be shy. Đừng mắc cỡ. Nào, nào, nào. Come on, come on. Okay, Lee. Is that you, Lee?
I see a mass with papillary architectures, a lot of papillary and there may be a epithelial hyperplasia inside.
Yeah, I think the thing what they want to show is this thing.
Can I see more?
So, yeah. Show you there.
Oh, it's like sebaceous.
Yeah,
cells.
yeah, that's right. Yeah. So the cell looks bad, isn't it? They look very atypical.
Yeah.
And I think it's a nipple skin.
Oh,
It's a skin of the nipple. Skin. Yeah.
skin. Yeah. Also, it's maybe a tumor of the annexal gland.
Yeah.
Maybe it's the sebaceous neoplasm.
Yeah. So sebaceous carcinoma. Oh, very good. Yeah. So sebaceous lesion. So CK56 negative, ER positive. I think androgen receptor is also positive, similar like that. Smooth muscle actin, true. Smooth muscle actin negative. Yeah, but I will P63 negative. Maybe she's thinking exclude SCC. BRAM. Now, be careful. BRAM can be positive in these things. So not everything is BRAM positive is melanoma. Yeah. This is positive. Adipofilin. Okay. Next one. This is not hard. This is easy. Next one. Who's next? Quick, quick. Come on. Your opportunity to talk. Maybe we move on to this side. All these guys are too shy. Next one, quick. We want to go to dinner soon. The sooner we finish. Okay. 50-year-old man with conjunctival lesion. So there, 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 there. Oh, there. So what do you say? Nói tiếng Việt cho nói tiếng Việt.
Tại mình thấy giống như một cái mô da ở dưới cái lớp biểu mô đó, nó có cái gì đó nó sáng sáng.
Đúng rồi, cái này nè, cái này màu xanh phải không? Cái này nó gọi là lúc mà mình ra mặt trời á, sun damage, solar elastosis. So what do you call the lesion? So what do you for myself? A lot of us have it, we don't know. So what do you sun damage? Basically, for the region, it's really not that's Sunday. Yeah, so you can really just sun damage areas. Okay, next one. Who's next? Ladies? Oh, yeah. 38. Don't know. 8. is what the history didn't say. I look like
Em thấy có một vùng xuất huyết nhiều và có cái cấu trúc tuyến. Ờ, tuyến này có vẻ là các tuyến tiết nhầy.
you translate that for me.
So,
No, my
Mucinous gland.
yeah, so she thinks there is two architecture in here. The first is the hemorrhage, and the second is the plain architecture, mucinous gland architecture. And mình nghĩ cái cấu trúc mô học này là gì nhỉ? Tuyến của cái gì đó?
Cái này là endometrial. Yes.
Yes.
So these glands are secretory, isn't it?
Em nghĩ là tuyến của nội mạc tử cung.
Secretory gland. Size or progesterone? Progesterone changes.
Phản ứng giả màng rụng.
Yeah. Secretory endometrium. Late secretory before she menstruates. Late secretory is correct. Correct, guys. It's Vietnamese translation. Very good. Come on, everyone get a chance. Come on, if everyone get a chance. One. 4 male gland and reproduction. My least favorite.
Các bạn mình cứ đứng lên thoải mái đi mình cứ nói tiếng Việt cũng được, không sao hết bạn. Không sao hết.
I saw I see the papillary architecture. It has a vascular. Yeah.
Bụng cóc.
Bụng cóc. Yeah, good. Bụng cóc. I'm learning something even good. Is that what you thought?
Yes.
Yeah. She thought more.
Mình thấy là một cái mô sợi, mô chủ yếu là sợi và mỡ, có một vài tuyến, có một ống tuyến lớn, có thấy có vài tế bào đơn lẻ rải rác trong mô sợi. Ờ,
là trong mô đệm có tăng sản mạch máu, benign,
Keep using mic. Okay, last one for this. 76, history of renal transplant, bladder biopsy. This is an interesting one. I think you should know this one. I like this one. Next one. Who is the gentleman next? The gentleman who's smiling. Yeah, there you go. So what do we have here? I'll tell you a secret. When you do, when you are asked to talk about something, I mean, I tell my medical student all the time. First thing, when you don't know what it is, you got to say something. Don't stand there and stare at the examiner, because he stare at you, you stare at him, you lose point. So you need to start describing. You can say anything. The tissue is from whatever, and you describe. And that buy you time. You start thinking, what am I describing? And then he can give you a hint. He say, look at this, look at that. So never stand and be silent, because silent would not gain you any marks. No marks at all in Viva exam. Trust me. So what do you have here? Bladder biopsy. They tell you it's a bladder lesion. So you know it's bladder biopsy. The history said, easy. The history said bladder biopsy. So you said section from bladder biopsy. What do you have here? Just describe, even you don't know what it is.
Thì em thấy cái mẫu thử này phủ bởi cái niêm mạc bàng quang. Và cái trong mô đệm thì có cái tuyến.
Is that right? Tuyến.
Yeah.
Tuyến là cái gì?
So he
Gland.
saw some gland.
Very good. He saw gland. Oh, he's halfway there. So that's the surface. Is the surface good? Good.
Yeah.
The surface good?
Yeah.
Yes.
Yeah.
That's a leading question. Whenever people ask, is it good? You always say, yes, it's good. You have to. It's all a game, this exam stuff. It's all a game. Got to know how to play the game. And then down here. So you saw these glands. Yeah. You know what they are? Oh, better go back.
So I heard someone that said it's a remnant. Someone just said that.
Remnant. Not remnant. Nephrogenic is good. What is it? Correct. Yeah. Full marks for him. Yeah. Very good. But that gentleman described as benign. You thought it's benign, isn't it? Benign, you're 50% there. So yeah, so that's very good. It's good to recognize this. Do you know what they stand for? You can do an immunostain to prove it. So nephrogenic adenoma, nephrogenic metaplasia. So it's quite worrying, because sometimes people think it's carcinoma, and it's important to differentiate from malignancy. Yeah, and I think we won't have time for the next talk. You can have a look. Yeah. So take-home message is, when you ask for any Viva, or as a medical student Viva, always, if you don't know anything, you don't know absolutely nothing, you don't know anything about anything, you start saying something. Describe. Even though describe, they show you a picture of an appendix, and you don't know, you can't see anything about the appendix. You start saying, section show an appendix, and you start describing. Just start saying, open your mouth, because if you don't open your mouth, you don't get any marks. Open your mouth.
Is giving your advice or your IELTS examination. Thank you, Dr. Kim Chen. Thank you for your wonderful presentation. Xin được thì xin được hôm nay thì chương trình của chúng ta xin được phép được kéo dài tới thời điểm ngày hôm nay. Thì ngày mai chúng ta sẽ tiếp tục chương trình với lại Dr. Sapa và Dr. Anita với lại hai phần chính, đó chính là các tổn thương tăng sinh của lympho cũng như là các tổn thương mà thường gặp của đường tiêu hóa. Xin rất là cảm ơn tất cả mọi người đã được tham dự trong buổi ngày hôm nay, cũng như là hy vọng sẽ được gặp lại tất cả mọi người tham dự vào trong ngày mai. Chương trình cũng sẽ bắt đầu vào lúc 8 giờ và sau đó chúng ta sẽ nghỉ trưa và tiếp tục chương trình vào lúc chiều. Và chúng ta sau đó sẽ kết thúc và tiến hành làm post test để nhận CME đối với các cái đối với lại các quý đồng nghiệp có tiến hành nhận CME. Rồi xin được phép cảm ơn tất cả mọi người đã tiến hành tham gia vào trong chương trình ngày hôm nay. I would like to thank you to our speakers for today. And give us your wonderful presentation and give us very wonderful advices about our practical daily for today. I would love to see you all of you for tomorrow. Yeah, for today.
When we started my session, you guys were quite shy. You don't want to open your mouth. But this session, I'm very proud of you. You guys are very active. You want to talk. You want to, but when you're still scared, but you are doing your very best. You're going to be very great pathologists later. I know that.
Thì chắc là mọi người cũng hiểu tất cả mọi điều mà cô Esther muốn truyền đạt. Thì cảm ơn tất cả mọi người đã tới tham dự trong buổi ngày hôm nay và hy vọng sẽ được gặp mọi người trong buổi ngày hôm mai. Rồi xin cảm ơn tất cả mọi người. Chúc mọi người có một buổi tối thật vui vẻ và một ngày chủ nhật thật là năng động.